ready?
You are.
Okay. I'm ready.
All right, go for it. Good show, everyone.
Welcome, everyone, to the first virtual TANGO2 Research Symposium. As we get started, let's find out where everyone is from. We have our first polling question. Wow, we are definitely a very international group here today. There are attendees from over 12 different countries. Welcome, everyone. My name is Kasha Morris, and along with my husband, Mike Morris, we founded the TANGO2 Research Foundation in 2018 after our son Ryan was diagnosed. Along with the board of directors and members of the research committee, we are very excited to host 7 speakers today sharing their latest insights on TANGO2 disease. All of the speakers were awarded research grants from the foundation and have spent the last year learning more about this rare disease. Each speaker will have about 20 minutes to speak, followed by 10 minutes of questions and answers. Many families have shared some great questions, and we are looking forward to hearing from the experts. Before we get started, I just want to share some housekeeping information. First, we are happy to offer live translation in Spanish, French, and Arabic. Just click the interpretation button at the bottom of your screen and select from the language options. Thank you to all of our interpreters who are joining us today. If you have any questions during this event, you can click the Q&A button at the bottom of your screen. We will do our best to answer many of them during the presentation or during the Q&A sessions. If you see a question you like, you can upvote it by clicking on the thumbs up icon. And please remember that this symposium is being recorded. Do not ask personal medical questions that you would not want disclosed in a public forum. At the end of today's symposium, we will have a link to a survey about this event. So, okay, let's get started. Giorgio Pochettino of Italy is chair of the research committee and a parent to 2 children affected by TANGO2 disease. He will introduce our first speaker. Giorgio?
Thank you, Kasha. Thank you to all for coming to this important event. Our first speaker is a professor in the Department of Molecular and Human Genetics at Baylor College of Medicine in Houston, in Texas. She's one of the investigators at Baylor who first described the TANGO2 disorder in 2016. She is both a clinician and a researcher that has seen multiple children affected by this disease. She's an invaluable member of TANGO2 Research Foundation Board. I'm proud to introduce Dr. Seema Lalani.
Thank you, Giorgio, for that nice introduction. It's a great pleasure to be here, and I would like to thank the foundation for giving me this opportunity to talk today. I'm going to share my screen. All right. So today we will, in this next half an hour or so, we will talk about what we have learned from families, from these children. And we have learned a lot, but we have a long way to go. So these are beautiful faces of some of our children with TANGO2 deficiency, TANGO2 disorder. And their stories have helped us learn a lot about this disorder. And this research symposium is a perfect way to tell you what we have learned so far and where have we come and what is our path ahead. So as Georgia mentioned, it was in 2016 that we described this disorder, two groups, and at the same time, they were able to identify multiple children who were presenting very similarly with muscle breakdown and cardiac problems. And they were all found to have problems in this gene called TANGO2. Since that time, we have learned a lot about the presentation of this condition. And that's what I will try to emphasize today. So we have learned that these children have baseline medical problems. And then, of course, we know about the metabolic and cardiac crisis that they have, which can be life-threatening, and they are urgent to address. And then we have children who are presenting with episodic spells, and they have unexplained symptoms that come and go. In our 2019 TANGO2 family conference, one parent described this as intermittent random episodes. And now in this symposium today, I hope to show you what those episodes look like that parents have been aware for a long time, but they could be so intermittent and so transient that doctors may never get to see. So we'll discuss those as well. So what are the baseline problems? They have the best smile. I love that fact about our children, and I don't know if it's part of TANGO2 deficiency, but they have the brightest of smiles. Baseline, they have learning problems, cognitive delay can be seen. Some children have intellectual disability diagnosis. About half of our children also have seizures, and there are different kinds of seizures. The thyroid gland may be low functioning, so they have a diagnosis of hypothyroidism, several of them. And they may have wandering eyes, exotropia, the medical term for that. They may have walking problems because of tightness of lower extremities and speech difficulties. So these are some of the baseline problems that we see. What kind of seizures do we see in children? So they are all kinds. It can be a muscle jerk. They're called myoclonic seizures. It can be generalized tonic-clonic seizures. It can be partial, or it can be a seizure where children suddenly lose their balance and drop to the floor. It's called atonic seizure. And for some of them, seizures can be difficult to control. What we have learned is when children have difficult to control seizures, they are ketogenic diet is tried on them, and we've seen experiences with these families that this has initiated a metabolic crisis and caused significant regression in some children. So at this time, although we don't understand the reasons, we are telling physicians to avoid ketogenic diet in children who have TANGO2 disorder. I wanted to show you some example of the speech difficulties they have, and you can appreciate when this clip is over what problems are seen.
All that makes me the happiest to treat my teammates on that. Let's go teammates, because you guys, you can do it.
What do you see? There's a bit in the yellow box.
Look at dog too.
Yeah, we can't touch that one though.
Ouch.
It'll give you owies.
So you saw that these the speech is difficult to understand in some of them. Sometimes there is slurring of speech, and we've seen nasal speech at times too. So let's talk about these episodic spells now. These symptoms that are described mostly from our natural history study, and this is what I've put down here. So these are symptoms that come and go without any explanation. And as I said, sometimes they're so transient that nobody is witnessing those episodes. It is described by intermittent abnormal posture, unexplained head tilt, unexplained body tilt, and whatever the child is doing suddenly is unable to do for a short period of time. There's loss of muscle control, the balance becomes off, and they can be extremely tired. At times, weakness is something that comes up. And during these episodes, their speech becomes slurred. They may have drooling, they may have swallowing issues. But the thing is, they usually tend to return to baseline within an hour or a few hours. Sometimes it takes longer, but these are spells, intermittent, random episodes that are described by the families. And I'm grateful to Dr. Kimberly Haug. She's a neurologist at Texas Children's Hospital, and I have shown her some of the videos that you all kindly shared with me of your children. And these are the medical terms that you might see in their medical chart. And I wanted to just give a term for these involuntary movements that you are witnessing. So Dr. Haug says that these could be described as paroxysmal dyskinesia. So these are abnormal movements, intermittent, abrupt in onset, without loss of consciousness. And then the sudden loss of muscle tone, it can be described, the weakness is paroxysmal hypotonia, which affects the trunk. And it's difficult for children to sit up or walk. And then there are children who have significant tightness or spasticity with increased tone of the extremities. And that can be manifested as toe walking, or a gait which is crouched, or they have scissoring of their gait. So these are some of the medical terms that you might see in the chart. Dystonia is when they have the head tilt, impaired motor function, and unexplained fatigue. So let's see if I'm going to show you a clip of these videos. And again, thank you all for sharing these with us today. The head tilt, parents have been seeing this for a long time before physicians are seeing this. So it's very important for clinicians to make this diagnosis from these manifestations that they are experiencing. These are not crises. These are intermittent episodes, and they are a clue for clinicians to pick these children before they have their first crisis. You can see the body tilt, and they look so similar. It's unbelievable how similar these kids are presenting. Same thing, you see. It becomes very difficult for them to continue to do what they are doing because of these involuntary movements. And this is very fascinating to me because this little girl has been having similar episodes of dystonia, involuntary movements, loss of muscle tone, lack of balance. And then within an hour, everything changes and she's running around like nothing really happened. Parents have been seeing this for a long time, but I think this is what clinicians need to see and diagnose children with TANGO2 based on these intermittent random episodes. Lack of motor coordination, again, that's what we are seeing here. And then difficulty to walk or crawl all of a sudden, like a child would be doing completely normal things before and all of a sudden is unable to. These kids are so similar in presentation. This is an example of extreme tiredness that comes out of nowhere, can take hours or days to go away. And then here is an example of the gait and the tightness that we talked about. So that was the intermittent episodes, and now let's touch briefly about the crisis episodes. So these are triggered by infection, a child who all of a sudden is not eating or drinking or is sick, gets dehydrated fast, and that's something that we have to be aware of and catch this quickly and take them to the ER as soon as they are exhibiting these symptoms, so they can have low sugar during these episodes. Their urine will turn extremely dark because their muscle is breaking down during these, could be breaking down during these episodes. And during this time, they could be susceptible to arrhythmia. A child who is in that state may just refuse to walk, just unable to walk, maybe disoriented, even in a coma state. And these are some of the lab values that are abnormal, including glucose, lactic acid, and ammonia. And this acute presentation can be life-threatening, and unfortunately, we have lost some children due to fatal cardiac arrhythmias during these episodes. It is very important to prevent this episode because we have evidence that with such an episode, there can be significant regression in development. So what is required for these children? So this is children who are otherwise healthy, not in crisis. What do they need? Who do they need to see? So they have to see endocrinologists. We recommend that because of the risk of hypothyroidism. We want them to have a neurologist to manage epilepsy, and if needed, their movement disorders. We refer our children to developmental pediatrician to have a baseline, and then we recommend therapies, physical, occupational, speech therapies. And most of them have a cardiologist, and we've also seen, and Dr. Miyake will talk more about that, but the cardiac crisis, we have not seen this. The cardiac manifestations, we have generally not seen this outside of crisis episodes. So the rhythm abnormalities, the cardiomyopathy is usually something that we see when a child is in crisis. Absolutely avoid fasting, dehydration, and ketogenic diet so far that we know about it, because this can precipitate severe metabolic crisis. There should be an emergency plan in place to initiate steps to minimize the risk of life-threatening problems during these crises. And we have an emergency letter, which is in place for families to keep a copy of and take it to the ER. It's now been translated in a few other languages. And we hope that by having an emergency letter like this, we are able to save lives, and these children are not waiting forever in the emergency room to be seen. Let's go into the genetics of TANGO2 disorder. So it's basic, but I'll still explain this because I think it is very important. So human body is made up of trillions of cells. And this is an example of a cell which has a nucleus inside, and inside the nucleus, you have chromosomes. If you unravel the chromosomes, it is made up of thousands and thousands of genes. This could be an example of TANGO2 gene. In these chromosomes, we have approximately 20,000 genes that are all packaged together on these 23 pairs of chromosomes. So if you take this gene, which is, let's say this is TANGO2 gene, it will make a protein, which is the TANGO2 protein. And this TANGO2 protein has a very important function because we know that when this protein is not functioning well or is absent, the cell is stressed and the cell is not happy. And then if the cell has energy problems or whatever problems, it's it has without the presence of TANGO2, the body is affected. So, and this is not just a protein that we can take externally and eat and make it better. This is a function very specific of this gene, the TANGO2 gene, to make a TANGO2 protein. And you'll know more about that as other speakers come on. So everybody has 2 copies of TANGO2 gene. And the problem only happens when both copies are affected. So that's important to know. Both copies have to be affected. The gene is on chromosome 22, which is a small chromosome. And because both copies have to be altered to have the disease, this disease is therefore a recessive condition. Here is an example of somebody who is healthy, both 2 copies of TANGO2 are working. This is an example of a parent of a child with TANGO2 disease, where 1 copy is completely fine and the other is not working. So this would be, again, a healthy person, but a carrier parent. And the problem happens when this carrier parent marries a partner who also is a carrier, and therefore there is a 25% chance in that union to have a child who's affected with TANGO2 disorder. So what are the specific types of the changes that affect the gene? The way I explain to my families is that imagine that there is a book which has 20,000 pages, and each page has a function. TANGO2 is one of those pages. So you could have a missing paragraph of the TANGO2 page as seen in this book. Or you could have everything intact, but there might be a little misspelling in this page, which is enough to make this gene non-functional. So these are the 2 kinds of changes that we are seeing. And the missing paragraph, or we call deletion, is one of the most common changes we have seen in children. And you will hear it as 3 to 9 exon deletion. And all it means is that from exon 3 to exon 9 of this gene, which is the coding part of the gene, is deleted. So basically, the protein, as I mentioned, the TANGO2 protein is not made. This is the most common form. And then you have the misspelling. And one of the questions for the symposium speakers was if it mattered, if the children would present differently, if this was the problem or the second one was a problem. And we have not seen a difference in terms of presentation for these children. They all present the same way. Then this testing can be done via single gene sequencing, or you can pick a panel for seizure, rhabdomyolysis, or hypoglycemia, low sugar panel that has this gene included to make a diagnosis. And of course, you can pick the whole exome sequencing the way we did in 2016 to test for all the 20,000 genes plus the microarray, and that's how we got to this diagnosis. Then there are some children who have interesting comorbidity, which means that there is a condition called 22q11 deletion syndrome, and it's a DiGeorge syndrome. People have known about DiGeorge for the longest time because it presents very differently. You have a child who's born with heart defect, immune deficiency, and has a hole in the palate. Multiple genes are missing in this syndrome, and it's called 22q11 deletion syndrome. But then we have now found children whose second copy of TANGO2 is also not working properly, and you have all other manifestations of TANGO2 disease on top of a child who has DiGeorge syndrome. So we are picking more of these children now too. So yes, TANGO2 must have a very important function. And it is important to understand the function of the TANGO2 protein, because if we are trying to get to the treatment of this disorder, we need to know what TANGO2 is actually doing inside the cell so that intervention can be planned, drugs can be made to address the the defect in the functioning of this protein. As you hear more from other speakers, I just wanted to introduce towards the end 3 organelles in the cell that you'll hear about: Golgi, mitochondria, and endoplasmic reticulum. Mitochondria are powerhouses of the cell. They generate energy. In endoplasmic reticulum, there is trafficking of proteins that are made inside the cell. Again, they have very important function. They need to get to Golgi, be packaged, and then sent out. And again, we are now seeing that there could be a problem with the Golgi ER trafficking or problems with mitochondria. And I'll leave that to the next speakers who will be coming. Just wanted to introduce you to these. So just wanted to end with this. We are doing this for our kids, and we are on the path to making a difference. Thank you for your time. I can take questions.
Great, thanks, Dr. Lalani. There is a question from the audience. Do you see similar episodic episodes, such as the head tilt, in other neurologic conditions?
Yes, and this is exactly the question that I was asking Dr. Hauk yesterday. And there is the paroxysmal dyskinesias. These are a group of disorders that are caused by problems in the channel genes. And this is seen in those disorders. And David, I'll be happy to send you the paper that Dr. Hauk sent me.
Great. Are there any other questions for Dr. Lalani? Please put them in the question box. Okay, so the next question is, have you seen any patients without cardiac involvement?
Yes, definitely. And again, Christina, this is your area, but yes, we have seen children, again, if they've not had crisis, we have not seen cardiac problems in them.
Okay.
All right, do we have a few minutes? I don't know who's keeping. Kara, do I have time to address some more questions? I had some in my slide.
Yes, you do. You have 8 minutes left.
Okay. All right, so these are some of the other questions that the attendees had submitted. So different forms of presentation of the disease, and we talked about that. Variations are variations related to the number of TANGO2 copies and deletions. And again, I think I touched on that it doesn't matter what kind of change you have in TANGO2. Is there a raised hand? All right. Cognitive decline, that was another question. Yes, Hugo, you can go ahead.
Okay, there is one question from the audience. Seema, I don't see any raised hands, but there's a question. Paroxysmal dystonia is, it says is usually related to other, sorry, this looks like an answer to other gene mutations.
Yes.
Yeah.
Okay, got it. Yes, that is right. Is there cognitive decline? And that is a question that parents have been asking, is this a degenerative disease? So I think there is cognitive delay, but we don't know if this is progressive. That's why we are exploring that in our natural history study. I think these children need multiple developmental assessments at regular time, and those children especially who've never had crisis, who don't have epilepsy, and to see really what their profile is like. I think we need more data to address that. Has TANGO2 mouse model trial shown helpful information for the scientists, been extrapolated to help families manage the disease? we are very fortunate that we have a TANGO2 mouse model that our researchers are working on. And so the data are not yet published. I know they're working hard on that, and we all look forward to hearing the data when it comes out. Next is, did TANGO2 exist in the past? Why it was discovered? Yes, it definitely existed in the past before 2016, but the children were losing lives without knowing what their diagnosis, without the families knowing what their diagnosis was. So yes, unfortunately, we have lost children without ever being diagnosed. So now we have a name for this. Is any research being done with unaffected sibling cord blood? A good question. So this is, we are very new, as you know, in terms of knowing a rare disease. And this is something that definitely will be coming up more in the future. As far as I know, not yet. Is there any fertility issues for TANGO2 kids? We don't know the short answer to that, but we know that they don't really have short stature, they don't have delayed puberty, but more work needs to be done about whether they would have any fertility issues or not. So I think I am done. I'm all done with
There
my.
is one more question, Seema.
Okay.
So from Blake, are there any ideas on why TANGO2 seems to affect children at different severities? For example, some are in wheelchairs.
No, so again, we have so much to learn. Like, I feel that children who have had crisis and have lost, have significantly had their muscle tone altered, they're unable to walk, they would be severely affected. Children who've never had crisis and they are in wheelchair, we need to know more about what really happened. Maybe there was an event that was a crisis but was never considered or never recorded as a crisis.
Okay, and one last question from Mike. Are seizures connected to crisis, initial or ongoing?
Good question. So in crisis, you can definitely have seizures, but we've seen more of baseline in children who are affected with seizures. Kids with 22q and TANGO2 more severely affected. Again, Debbie, that's a good question. We know that our collaborators at Children's Hospital Philadelphia are also trying to answer this question. So we don't know yet. I'm sorry I keep saying that, but there's so much more to learn, and this is just our one way to move forward. All right, thank you so much.
Thank you both, Seema and Dr. Miyake, for this information. I think all the stakeholders here today learned something from this information. Next, we have David Longman from Australia, who is a dad, a TANGO2 dad, and a member of our research committee. He will introduce our next speaker. David?
Hello, everyone. I'm proud to introduce our next presenter, who is an assistant professor in the Department of Pediatrics and of Neuropediatrics at the Heinrich Heine University, Düsseldorf in Germany. He mainly focuses on the identification and characterization of rare neurometabolic diseases. He is one of the investigators from Germany who first described the TANGO2 disorder in 2016. I am pleased to introduce Dr. Felix Distelmaier.
Yeah, thanks a lot for the introduction. I'm very happy to be here today. And thanks a lot to the TANGO2 Research Foundation for giving me the opportunity to speak here today. And yeah, I was also thinking a lot actually when I was asked to present what kind of data I should present today. Last time when I joined the TANGO2 Family Conference, I presented quite some basic research data from our lab. And I think this time Michael Sacher, who's also going to present today, will present quite some basic research data. And therefore, I decided to do a more clinical presentation. So I will share my screen. Hope that works. Okay. I guess you can all see the presentation.
Looks good.
Okay, perfect. So my question, or the question I would like to address today is in what kind of category of metabolic diseases TANGO2 actually belongs? Because I think that's an open question since the first description of TANGO2 deficiency. And well, in Düsseldorf at the clinic where I work, I'm taking care of the patients with rare metabolic diseases. I'm mainly focusing on mitochondrial diseases, but I see all the other metabolic diseases as well. And the first TANGO2 patients that we saw in Düsseldorf, we thought that there were, for example, lipid metabolism disorders. That was our idea, but we could not find them. The mutation that we were searching for in the group of lipid metabolism disorders that we were thinking about. And since that time, I'm still thinking about where do we need to put TANGO2 deficiency in terms of a metabolic disease. And if we look into the literature, there are several large metabolic disease groups which are mentioned in the context of TANGO2 deficiency. And one important group are the lipid metabolism disorders. These are, let's say, genetic defects causing problems with a breakdown or metabolism of fatty acids in our body. And there are many different enzymatic defects known, and patients with these disorders can have various very similar symptoms compared to patients with TANGO2 deficiency. The other group of diseases which is frequently mentioned in the context of TANGO2 deficiency are the mitochondrial diseases. Mitochondrial diseases are a very heterogeneous and very large group of metabolic diseases, and I think it's very difficult to compare TANGO2 deficiency with the mitochondrial disease because there are so many, but at least there are some core clinical features that mitochondrial diseases and TANGO2 deficiency also have in common. And also here I will give you more details during the following presentation. Apart from these disorders of lipid metabolism and the classical mitochondrial diseases, there are more disorders which also show an overlap with TANGO2 deficiency. For example, the disorders of mitochondrial cofactor metabolism. So these are not diseases directly affecting the respiratory chain, but they are indirectly related to that. Or, for example, more recently described diseases like the trapopathies, which are defects in ER to Golgi trafficking. And this, as we heard from Seema, is also a problem that is definitely there in TANGO2 deficiency. Now, in the following, I would like to give you some details on lipid metabolism disorders and in how far they are comparable to TANGO2 deficiency. And I picked one disease where I think there are striking similarities to TANGO2 deficiency, and that was actually also the differential diagnosis that we had in mind during the time when TANGO2 deficiency was not described, and that is the carnitine palmitoyltransferase 2 deficiency, so CPT2. Well, the CPT2 enzyme is located at the inner mitochondrial membrane, and it is important for transporting long-chain fatty acids from outside the mitochondria inside the mitochondrion for further metabolization. And it works closely together with the CPT1 enzyme, which is located at the outer mitochondrial membrane. So both proteins work together to get the long-chain fatty acids into the mitochondrion and to further metabolize them. Oops. Now, if we have a patient with this CPT2 deficiency, these patients can have very severe and acute symptoms that show quite an overlap with TANGO2 deficiency. First of all, these patients can have acute metabolic crisis with severe rhabdomyolysis, as we see in TANGO2 deficiency. They can have hypoglycemia and also lactic acidosis during these crises. They can have lethal or very dangerous cardiac arrhythmia, especially during metabolic crisis, as it is the case for TANGO2 deficiency. They can develop liver damage and also elevated ammonia during crisis. And they show neurological problems like epileptic seizures, developmental disabilities, various movement disorders, depending on the severity of the crisis and the clinical course. So I think there are many similarities compared to TANGO2 deficiency. On the other hand, there are also some differences. For example, in CPT2 deficiency, there's usually no thyroid dysfunction, which is a frequent feature of TANGO2 deficiency. And in patients with CPT2 deficiency, we have a very typical metabolic signature, especially during metabolic crisis, which is the elevation of specific acylcarnitines, so breakdown products of lipids, which then accumulate in blood and which we see during our metabolic investigation. But sometimes we see abnormalities there in TANGO2 deficient patients, but it's not so obvious as for CPT2 deficiency. If we look at muscle tissue of patients with CPT2 deficiency, which is here depicted in the lower right, we see, especially in the later onset forms, an accumulation of lipids, which are these red dots here, which are not present in a healthy person. And I'm actually not aware that this is a feature of TANGO2 deficiency. At least I've not seen that before. So there are many similarities, but there are also some differences if you compare CPT2 and TANGO2 deficiency. Now, the question is there any specific MRI feature? So is there any specific brain damage that happens in CPT2 or TANGO2 deficiency? And actually, so far, there's no classical, let's say, damage pattern described. But interestingly, at least, I found these two pictures here. So that's actually from one of the patients from Düsseldorf. And this is a case report from a patient with CPT2 deficiency. And first of all, these MRIs do not show a specific pattern of damage. But at least you can see that these inner ventricles, so the inner CSF spaces, are mildly elevated in CPT2 deficiency, and that's quite similar to TANGO2 deficiency, for example. And during crisis in CPT2 deficiency, you have these bright areas on the brain surface in this patient with CPT2 deficiency. And for example, here in the TANGO2 patient, you also have that. That can be just caused by seizures, but at least it was striking to me that it looks quite similar. And that might be also just stimulating maybe further clinical research, because I'm not aware of any neuroradiological study on TANGO2 deficiency. And maybe it's really worthwhile to go more into detail, because at least from our patients, I know that they all had this aspecific widening of the inner ventricle, so the inner CSF spaces. Now, if you look into the literature, is there any evidence for a disorder of lipid metabolism in TANGO2 deficiency? And well, there's still a lot of information lacking. But for example, if we look at this article from the Rita Howard group from 2019, they did a proteomic screening. So they analyzed the proteins in patient cells with TANGO2 deficiency. And what they found is that many proteins involved in fatty acid metabolism were, let's say, dysregulated. And for example, this SLC25A20 gene was or protein was downregulated, and that's interesting because that's the transporter which is sitting right between CPT1 and CPT2, and which is also involved in the transport of long-chain fatty acids into the mitochondria for long-chain fatty acid metabolism. Now, the question is, if we think that CPT2 deficiency and TANGO2 deficiency has a lot in common, then the question is, can we also adapt treatment regimens from CPT2 deficiency to TANGO2 deficiency? And for CPT2 deficiency, there are at least quite some recommendations available because we know this disorder for a long time. And important recommendation, for example, that there should be restriction of lipid intake and increased carbohydrate intake. And especially for the early onset young patients, we have specific diets available which are high in medium chain triglycerides and low in long chain triglycerides. And we know that especially the application of long chain triglycerides is potentially toxic and potentially triggering metabolic crisis in these patients. And as you can see, there are commercially available nutritional compounds that we can use in these patients. In addition, patients with with a CPT2 deficiency get carnitine, which is a nutritional compound, which is used as a detoxifying agent. So it's supposed to convert the toxic long chain acyl-CoAs and to eliminate them from the body. Another recommendation is to avoid fasting situations. That's a very general recommendation, which holds true for most metabolic diseases. So that's not very specific, but it's at least one of the recommendations. Then during crisis, adequate caloric supply, or at least also to prevent crisis, adequate caloric supply by glucose infusion is recommended. And very important, intravenous lipids are contraindicated because we know that intravenous lipids, especially if they contain these long-chain triglycerides, can trigger acute metabolic crisis in CBD2 deficiency. Now the question is, is this treatment, is the CBD2 treatment applicable to TANGO2 deficiency? And if we think about that, I think it's very important to talk about the potential risks. Can we do any harm if we try that? And one important question is, of course, if we increase the amount of medium chain triglycerides in the nutrition of TANGO2 patients, can that cause any problems? Because we don't know, is it really a problem with long chain triglycerides that these TANGO2 patients have, or can also the medium chain triglycerides maybe cause problems? So that's an unsolved question. And the other thing is that L-carnitine supplementation, which is a standard part of the standard care in CBD2 patients, has been linked to cardiac arrhythmia in patients with TANGO2 deficiency. At least there were reports from the Paris group that L-carnitine supplementation might cause problems. So therefore, I think regarding L-carnitine, we have to be cautious and maybe we should not give that. Regarding the MCT-based diet, I had now contact with a group in Freiburg where they focus on lipid metabolism disorders in Germany, and I was talking to the Charité where they also have a large metabolic unit, and at least in Freiburg they have one patient where they tried a treatment which is MCT based, where they did not see any problems so far. And in Berlin, we are now trying together to treat one TANGO2 patients with an MCT based diet, and we have to see what the outcome is. Okay. Now, the second part of my presentation will now be on the mitochondrial diseases, because this is the other disease group which is frequently mentioned together with TANGO2 deficiency. And as I said in the beginning, mitochondrial diseases are a very large and very heterogeneous group of mitochondrial diseases, of metabolic diseases. And they can cause a lot of symptoms, and they can affect any organ system. They can damage the brain in many ways, and therefore also cause different types of neurological problems, for example, movement disorders, like ataxia, dystonia, similar things as we have seen now for the TANGO2 patients in Seema's presentation. They can also affect the peripheral nervous system, so cause peripheral damage to nerves. They can affect the skeletal muscle, for example, in terms of muscle weakness. They can cause epileptic seizures. They can affect the eye with retinopathy or atrophy of the optic nerve. They can cause developmental problems in many ways. The heart can be affected most of the time in terms of thickening of the heart muscle. They can affect the endocrine system, also the thyroid gland, and they can also affect the gastrointestinal system. So, for example, the liver or the intestine. As I said, mitochondrial diseases are a very large group of diseases, and today we know more than 300 different genetically defined mitochondrial diseases, and they can be very different in their clinical presentation. But at least there are some clinical core features that they have in common, and I here try to compare them with TANGO2 deficiency. And also here we have some overlap. For example, patients with mitochondrial disease can also have hypoglycemia and lactic acidosis, especially during metabolic crisis. They can have neurological symptoms like seizures and developmental problems, which is also then TANGO2 deficiency. They can cause cardiac arrhythmia, although from my experience, cardiac arrhythmia in patients with mitochondrial disease is mostly triggered by cardiomyopathy in terms of thickening of the heart muscle. And if the heart muscle gets very thick, that also increases the risk for arrhythmia. In patients with CBD2 deficiency or TANGO2 deficiency, it's more the acute crisis and toxic compounds which cause the cardiac problem. Then liver damage can be also there in mitochondrial disease, and thyroid dysfunction is also a potential feature of mitochondrial disease. However, I think there are many differences also between mitochondrial diseases and TANGO2 deficiency. For example, the rhabdomyolysis, which is a core feature of TANGO2 deficiency, is very atypical for a mitochondrial disease. There are very rare reports on rhabdomyolysis in patients with mitochondrial disease, and I've never seen that actually in my almost 20 years experience of working with mitochondrial disease patients. The brain imaging pattern, well, there are very typical examples how mitochondrial diseases can affect the brain, and I will show them on the following slide. I mean, we also have mitochondrial diseases with very aspecific, let's say, brain damage or brain imaging patterns. But for many mitochondrial diseases, we have quite specific findings. And that's a difference to TANGO2 deficiency. If you look into the muscle, so if we do a muscle biopsy in patients with mitochondrial disease, we normally find abnormalities, so respiratory chain deficiency. And in TANGO2 deficiency, that's at least not a consistent feature. Sometimes it's there, sometimes it's not there, which indicates that respiratory chain deficiency is not a primary feature of TANGO2 deficiency. And also other markers, blood markers of mitochondrial disease, like FGF21, for example, are not elevated or not typically elevated in patients with TANGO2 deficiency. These are now examples how mitochondrial diseases may damage or affect the brain. A very typical feature is this very symmetrical affection here, for example, of the so-called basal ganglia, which are important areas in the brain for movement control. So you can have these very symmetrical lesions here, but also in the brainstem, so further down in an area which is important for the control of heart rate or breathing or temperature control. But you can also have an affection of the white matter, which are these irregular bright spots. And you can also have focal lesions like here or here, which is the case in the so-called MELAS syndrome, which is a mitochondrial disease that causes so-called metabolic strokes. And in addition, if you do an MR spectroscopy, which is depicted here, that's a metabolic investigation of the brain, you see increased levels of lactate. That's the peak going downwards here in the brain tissue that is affected. And that's also not a feature that is always there in TANGO2 deficiency, or that's typical for TANGO2 deficiency. Now, how about treatment for patients with mitochondrial disease? The problem with mitochondrial diseases is that there is no ideal or perfect treatment available. But one treatment strategy is definitely the application of vitamins or cofactors, which is sometimes called a mitococktail. And the idea behind giving vitamins or cofactors together with the nutrition is that, for example, some of these vitamins might be able to stimulate the activity of the mitochondria because they are substances that support the mitochondria and their function. And we know that some vitamins can also stabilize certain respiratory chain enzymes. Another important aspect is the antioxidative protection. So many vitamins are able to capture oxygen radicals and to reduce oxidative stress. And that's one feature that is present in mitochondrial disease and might cause tissue damage. Another idea is to improve cellular energy pools. For example, in muscle weakness, the application of creatine is something that we try. And for example, supplementation of secondary deficiencies. So in patients with mitochondrial disease, sometimes the lipid metabolism gets also affected. And there, for example, the supplementation of L-carnitine is frequently done. Now, what's the evidence for this mitococktail? Well, first patients treated with this kind of regimen were reported in the early 80s from the last century, and then many case reports came out, and everybody tries different things, but there are no large clinical studies that really investigated the effect of these vitamin supplements. And there was one comprehensive review, which is some years old now, and they tried to find out if the mitococktail has any benefit in mitochondrial disease, and the conclusion is that there's actually no clear evidence for that. So that means for us treating patients with mitochondrial disease, we can try to give these vitamins, but it's not generally recommended, and it's hard to say if it does any good. Now, the question is there anything in the treatment of mitochondrial diseases that we can that is applicable to TANGO2 deficiency, or that we can transfer to TANGO2 deficiency? And again, I would like to talk about the potential risks. And I think there's some important risks that we have to consider. First of all, in patients with mitochondrial disease, it's more or less standard to also give intravenous lipids, especially if they come and they're not eating well, if they have fever, or if they're in a fasting situation, to supply calories. So normally we give glucose infusion, but we also add lipids, and lipids are a good way to provide a lot of calories in an easy way. But giving intravenous lipids, from my point of view, should be contraindicated in patients with TANGO2 deficiency, because there's so many indications that there's a problem with lipid metabolism. So therefore, I would definitely not do that in a TANGO2 patient. And we know, as Seema already mentioned, that if you give fat-enriched diet, so the so-called ketogenic diet, to patients with TANGO2 deficiency, that this can trigger acute metabolic crisis. And I think that's a strong indicator for me that TANGO2 deficiency has a very severe problem with lipid metabolism. If we look to the Mito cocktail, I think, well, giving that to patients with TANGO2 deficiency will probably do no harm. But as I said before, I'm not really convinced that it helps. Regarding L-carnitine, it's the same as I mentioned for CBD2 deficiency. I would not give that at the moment because there might be indications that it causes cardiac problems. And I think this is something that needs to be investigated further in the future. Then coenzyme Q10, I think, is an important topic because at least in one publication from the past on TANGO2 deficiency, it was mentioned that in some patients with TANGO2 deficiency, coenzyme Q10 levels were low in muscle tissue. But I think it's not a consistent finding. For example, we investigated patient fibroblasts regarding CoQ10 biosynthesis, and we did not find any abnormality in TANGO2 deficiency. So I think it's unlikely that they really have a primary problem with CoQ10 in TANGO2 deficiency, but giving CoQ10 will probably do no harm. However, you have to keep in mind that coenzyme Q10 has a very low oral bioavailability, so it's poorly taken up from the intestine, and it's also not penetrating well into the central nervous system. So even in patients with primary CoQ10 disorders, we frequently see that CoQ10 treatment or supplementation is not really helpful. So I'm not convinced that this will help in patients with TANGO2 deficiency. Now, I would like to conclude, to summarize some things. First of all, I think if we look to other metabolic diseases, there are very important overlaps between TANGO2 deficiency and lipid metabolism disorders. And if we now lipid metabolism disorders and mitochondrial diseases, I think there are more similarities between lipid metabolism disorders and TANGO2 deficiency than between TANGO2 deficiency and mitochondrial diseases. So I think that there's definitely the metabolic problem from my point of view. Therefore, I think adapting treatment concepts from lipid metabolism disorders to TANGO2 deficiency might be an important step to improve the care of these patients. However, there are still some risks that we need to consider. And I think here it's important that metabolic clinicians or people experienced in treating metabolic diseases come together and try to find concepts and maybe also work together in terms of clinical experiences on TANGO2 patients and maybe even on trying these kind of treatment concepts and talking about risks and what was seen in their experiences. And therefore, I think clinical studies or at least further discussion on that topic might be important to decide in how far we can further development or how far we can further develop the nutritional treatment of TANGO2 patients in the future. Yeah. So I'm finished with my presentation and I'm happy to take your questions.
Thank you, Felix. So we will wait for questions to come. And until those come, I do have some of the questions from the attendees from before. And let me see if I can answer, I can ask you those. So Felix, some of the questions that I thought you might be able to answer better. All right, so there's one question. Is there a role for a specialized diet in TANGO2?
I think that there might be a role for a specialized diet. I think that, as I explained during the presentation, we see that, let's say, for example, giving excess lipids to patients with TANGO2 deficiency is harmful. So ketogenic diet may trigger crisis, and that indicates for me that giving too many lipids is a problem. And I think what we need to find out is if maybe the long chain fatty acids are causing the problem. I think that's maybe an important task. And As I said, I discussed with the people from the Charité, and I also discussed, for example, with Freiburg, and I also discussed with Pascale deLonlay on the treatment of TANGO2 patients in terms of restricting, for example, lipid intake and maybe giving a low long-chain triglyceride and high medium-chain triglyceride diet, and that might be a way. And I think it's important that the clinicians discuss these aspects, and maybe we should also involve more metabolic centers and ask them how they see this metabolic constellation, and then we need to decide if we dare to do some kind of treatment in TANGO2 patients.
Right, thank you. Another question, how close are we to having a treatment?
I think that's difficult. Yeah. So I think that there are two aspects. One is basic research, and basic research, that's always the problem, that takes time. And I mean, many affected patients, they would like to have treatment very soon. And the difficulty is that basic research will take definitely longer. And I'm curious now, of course, about the presentations which are to come, to see how far the other groups are and what kind of ideas they have. And I think the mouse model is also an important aspect, because that facilitates also then to try treatment concepts in a living organism that can be maybe easier than also translated into the clinical context. But I think having a perfect treatment, like a drug that we can give and that makes everything good, that will take time, or that's very difficult. But improving the care, that might be an important step forward. And especially in patients with CPD2 deficiency, I think, or I have many patients at my outpatient department, for example, where I see that with an adequate dietetic treatment, you can already gain a lot of improvement and prevent crisis and things like that.
Okay, thank you. All right, then we have from David Longman. Did you say some TANGO2 patients had elevated C12 to C18 at baseline, or only during crisis? Do CPD2 patients have elevations of these at baseline?
Yeah, I think we saw that for TANGO2 patients during crisis, but it's not a feature that we found in every patient. So in CPD2 deficiency, it's very typical during crisis. Sometimes it's not there if there is no crisis. That's the problem with almost any lipid metabolism disorder, that if they are not in a crisis, if they are well, if they have normal nutrition, no crisis, no fever, nothing, then sometimes also acylcarnitines, lipid profiles are completely normal. So then this is not visible for us, also from the metabolic lab. But if they have crisis, then these abnormalities come, and we have these abnormalities also in TANGO2 patients. But from what I've seen so far, it's not as consistent as a finding as in CPD2 deficiency.
Right, and then I have questions about carnitine and coenzyme Q10. So from Dr. Haug, what is the reasoning behind recommending against L-carnitine? Commonly, patients on valproic acid are supplemented with carnitine.
Yeah, so basically, the only thing about L-carnitine is that in the paper from the deLonlay group, I think they mentioned that they think that L-carnitine might trigger crisis. So I think that's an observation. I think it's not proven, but at least they mentioned this problem. And as soon as it is mentioned, I think you have to be careful. But I'm not convinced that L-carnitine is really dangerous. But of course, that makes it more difficult to just give it to the patients. I think maybe Pascale deLonlay can also say something to that. I think she will join us later then. And maybe she can tell us about her experiences with L-carnitine in TANGO2 patients.
And just to clarify, another question that I have, like CoQ10 is okay. It's not contraindicated, correct?
No, definitely not. I think it's not contraindicated. So let's say CoQ10 deficiency disorders are one of my research focuses on the mitochondrial diseases. So, and therefore we work a lot about giving CoQ10 to patients with CoQ10 deficiency disorders. And from what I know is that if we, for example, have a patient with a primary CoQ10 deficiency disorder and we supplement with CoQ10, mostly we cannot adequately treat this patient, although we think that, okay, now we are giving what this patient is lacking, and still it doesn't work. So we are not really sure why CoQ10 is not doing the job, but most probably it's not adequately going where it's supposed to go. And I think the same will probably happen in TANGO2 patients. And in general, I think that TANGO2 patients have no primary problem with CoQ10 biosynthesis, but they might have a secondary problem. So I think they also have a secondary problem with mitochondrial function. So it's not a primary mitochondrial disease, but also secondarily, of course, mitochondria get compromised. And as I explained, also CPD2 is basically a mitochondrial enzyme. So it's all located at or inside the mitochondrion, but the metabolic pathways are of course different.
Thank you. And then I have a number of questions regarding brain MRI findings. Why on one side? And then is it abnormal before crisis?
No, I think, well, I think we have enough information about that. I was actually searching because I'm interested in brain imaging, and I do a lot of, let's say, studies on that in mitochondrial disease patients. And I was just looking what we have, and I know that in the few TANGO2 patients that we described in 2016, I found it interesting that they all had these mildly widened inner CSF spaces, although they were clinically very different, but the brain images looked similar to me. And now I found just by accident this one CPD2 MRI, and I thought it looks very, very similar. And I think it would be very interesting just to collect brain MRI images and just to compare them. And now since we have this platform and there's so many parents now involved, so I think it would be interesting just to collect the images and just to do a larger study to see is there are there similarities, or is it more heterogeneous than I think? And also regarding the movement disorder that you showed in your videos, I think it would be very interesting again to look more specifically into the brain MRI images and to see is there maybe more than are there specific changes that we have maybe not realized yet that might be related to this type of movement disorder.
Great, thank you. I think we'll take one more question from Mike. Is there a standardized definition of what a mitococktail is and consists of?
No, it's not. So mitochondria is just, you could put anything in it. So the most of the time we have vitamin B1 in it, so thiamine, then vitamin B2, riboflavin, then most of the time coenzyme Q10, and then L-carnitine is frequently added because many severe mitochondrial diseases get secondary carnitine deficiency, so therefore we usually add that. And apart from that, there are many other things that you can add. So there are various combinations, and that I think makes it also so difficult to judge about the treatment efficiency. And it's important to know that some mitochondrial diseases have specific problems, for example, in the vitamin B1 or vitamin B2 pathway. And of course, they respond better than a mitochondrial disease that has a different kind of damage or problem.
All right, thank you so much, Felix.
Yeah, you're welcome.
All right, Kasia, all yours.
Thank you. Thank you both very much. We are off to a great start, and it is so encouraging to be hearing the latest thoughts on TANGO2 disease. Next up, we have Pascale Denisi from France, who is a member of the research committee and a TANGO2 parent, and she will introduce our next presenter. Pascale?
Yes, thank you very much. I'm very pleased to welcome our next speaker, Dr. Pascale deLonlay. She's a pediatrician and coordinator of reference centers in inherited metabolic diseases in France, the network G2M for children and adults. And she's also a coordinator of the unit of metabolic diseases at Necker Enfants Malades Hospital in Paris. And she's joined today by Dr. Hortense Calbiac, her postdoctoral fellow. Doctors.
So thank you very much for inviting us to present some slides to the meeting, and we thank the TANGO2 Foundation, of course, for our work. So I will present our emergency protocol. Of course, you will need to rework this protocol with all the teams who know TANGO2 deficiency, and Hortense will present animal model with zebrafish with TANGO2 deficiency. So we have in France 22 patients with TANGO2 deficiency from 16 families in the different reference centers in France, but probably we have more patients because we have probably patients with TANGO2 deficiency with only one symptom, not all the association of symptoms. So the patients were aged between 3 and 23 years. And as you know, we have the clinical association of acute and chronic symptoms, as Lina said. Acute symptoms are not obligatory. They associate neurological symptoms, hypoglycemia, muscle symptoms, mainly rhabdomyolysis, and cardiac symptoms. And chronic symptoms include neurological symptoms and hypothyroidism. And it's very important to know that we have, like in other diseases, an important clinical variability between families. For example, the neurological symptom can be very severe or mild and may be completely absent. It's the same for the hypothyroidism, and for the cardiac anomalies, we can have no hypothyroidism and no cardiac anomalies. And we have also an intrafamilial variability between siblings in the same family. For example, we have one family with a child very severe since 4 months of age with a severe encephalopathy, and his sister is 3 years old now, and she's completely normal. She has had no infection, no fever, no gastroenteritis, but she goes to school. Before she went a little to the daycare. So probably she was protected against the infection, but she goes to school and we need to build the immune system. So the children, I think, have to go to school even with a TANGO2 deficiency. So we give emergency certificates to the patients because we ask to the patients to go to hospital in the situation at risk of decompensation. For example, high fever, gastroenteritis. Why? Because we consider that, like in a lot of metabolic disease, acute decompensations occur in response to external triggers. So we do emergency certificates that we give to patients. So when they go to the hospital, emergency physicians know that patients don't have to wait to be taken care of and have to be infused immediately with glucose. It's the same for general anesthesia. They give the emergency certificates to anesthesists with all emergency telephone numbers for the physicians. So it's important to understand that TANGO2 is a new disease. So we are learning what to do with you, with the patient, and from other teams, of course. Also, these certificates will have to be modified, as you saw with Lina and the last talk, because we have some doubts. We are not sure with the certificates. We have some doubts for the lipids and for the carnitine. Regarding lipids, they were contraindicated at the start because the disease mimics fatty acid oxidation defect. This is another metabolic disease with a deficiency in fat utilization. And in this fatty acid oxidation defect, we can have abnormal acid carnitine profile in plasma. In TANGO2 patients, some patients had abnormal acid carnitine during acute crisis, not during basal condition. So in our cohort, acid carnitine in plasma were always normal. One patient in our cohort said that the lipids were not suitable, but now he takes lipids and is very fine. And finally, our metabolic studies in patient cell after palmitate administration, after lipid administration, were normal with any negative consequence on the cell. So now we give lipids to the patients, but we contraindicate lipids in infusion, of course. We don't load the lipids in the patients. It's exactly the same with the carnitine. We don't know for the carnitine. Carnitine is given to a fatty acid oxidation deficiency, but at low dose because it can lead to arrhythmia in fatty acid oxidation. So it made sense in giving carnitine to TANGO2 patients, but it was not mandatory because there is no decrease in plasma carnitine in patients with TANGO2 deficiency. And we have only one patient who had an arrhythmia, cardiac arrhythmia, immediately after the administration of carnitine. So the physicians of this patient were sure that the drug was toxic for this patient. So in the doubt, we contraindicate the carnitine, but we don't know if it's true. And we will learn in the future. So it's by observing the patients and better understanding the mechanism of the disease that we will know what to do. And there will be a need to standardize emergency protocols between teams, of course. So in the emergency certificate, we give the instruction, of course, glucose infusion, because the patients don't support fasting. Prolonged fasting is a trigger of decompensation, like for other metabolic disease. So we give in the infusion glucose with, at the beginning, no potassium, because maybe the patient will develop a rhabdomyolysis, and after we adopt electrolyte in the infusion to the ionogram monitoring, we give no lipids in intravenous infusion and no carnitine in doped. And of course, we measure some biological parameters, electrocardiogram and echocardiography because of the cardiac anomalies. And in this emergency certificate, we give the drugs contraindicated in TANGO2 disease. It shows that we have to contraindicate all drugs known to prolong QT interval, because you know that we can have a long QT in cardiological symptoms. Drugs containing lipid, L-carnitine maybe, and some other drug usually contraindicate in metabolic diseases. For the general anesthesia, you will give the emergency certificate to the anesthetist. Importance of the glucose, of course, no fasting, and maybe to choose the anesthetist to contraindicate some anesthetic, volatile anesthetics. And maybe if we have acute rhabdomyolysis, Dantrium, because rhabdomyolysis is the release of calcium, and we can block calcium channels by Dantrium. So now I will give the talk to Hortense with the model animal of zebrafish.
So, hi everyone, I am Hortense Calbiac. I am a postdoctoral researcher, and I've started to work on TANGO2 disease a few months ago, and I am very happy to be part of this very significant project. So I will talk about how we can model TANGO2 pathology in zebrafish model, which will help us to better understand the normal role of this gene and to screen molecules of interest to find therapeutics for this disease. So a few words about this model, about zebrafish, which is also called Danio-Herio, and it has come to rank as a model system of choice in the field of genetic diseases. Why? So first, it shares a strong homology to human genome. For example, there are 84% of genes known to be associated with human diseases that have a zebrafish counterpart, and it's the case for TANGO2. Plus, also it has the advantage, sorry Pascale, it's a bit earlier, but it has the advantage of quickly producing numbers of externally developing embryos, so it's a real gain of time in terms of experiments, so for the researcher. And also something that's very important for us is that zebrafish embryos are permeable to drugs. So we just have to put the molecules of interest in the water, which gives us a pretty high throughput. But I will come back on that later. So how do we mimic TANGO2 mutation in zebrafish? So to do so, we use a genetic tool that we inject in zebrafish embryos that comes to block TANGO2 expression. So this zebrafish loses the protein TANGO2, so just like the patients. And then we measure the effect of the loss of TANGO2 expression by a test which assesses their motor ability. So now you can change, Pascale, s'il te plaît. Pascale, je sais pas si... Ah non, juste la vidéo, juste avant.
Oui.
Voilà, la vidéo. Merci. So here I put a video of this test just to show you what we do in the lab. So this is a response of an embryo control, so that has no inhibition of TANGO2. La slide d'après, s'il te plaît, Pascale. And when we project on axis the trajectories of the tested zebrafish, as shown in the traces on the bottom left of the slide, we can quantify the swimming parameters of these embryos, such as the distance, for example, that they were able to travel. And this parameter can give us insight about the effect of the inhibition of TANGO2 in their system. So what you see here is that when TANGO2 mutation is mimicked in zebrafish, the zebrafish have troubles to swim, as shown by the decreased distance they travel that you can see on the bar graphs on the bottom right. So this decreased distance gives us a parameter to target when we test some drugs. So we are then looking for a drug that can increase the distance in the condition where TANGO2 is depleted. Alors la slide d'après, s'il te plaît. So what I wanted to show you here is this machine, which is called the viewpoint that we have in the lab that allows us to track the zebrafish swimming in an automated fashion. And with the high throughput, we can track up to 96 zebrafish at the same time. So basically what we do is putting the zebrafish into a plate along with the drugs that we want to test and ask the machine to track the distance that they traveled. So what we hope with this TANGO2 zebrafish model is to unravel the normal role of TANGO2 in vivo and to target the identified cellular mechanisms with drugs using this automated system. C'est bon.
So thank you very much, and we can answer to the questions. And we thank Sébastien Montelegre. You saw Sébastien last year, and now Hortense will rejoin the group.
All right, thank you so much. We have time for questions. So David Longman is asking if you can explain the difference between zebrafish AMO1 and AMO2.
Yeah, absolutely. Actually, that was two different morpholinos. So one was targeting the initiation of the translation of the gene, but this one didn't work as well as the second, actually, which is targeting a splice transcript of the gene. So the second one seems to have a better impact on the zebrafish. For now, we don't really know why, but for example, it can be just a question of degradation in the morpholino, for example, in the zebrafish, sorry, degradation of the morpholino.
Right. I'm also looking at some of the questions previously submitted to us. One of them is, what are your next steps in searching for a better understanding of TANGO2?
Pascale, tu veux que je réponde?
Yes.
So now what we want is to unravel the mechanistics of TANGO2, so in zebrafish and in neuroblast. So for that we have several tools. So I will talk about the zebrafish tools, but we can look at the muscles, for example, to know if there is a defect in the muscles. We can look also at the heart. So we can look at different tissues like that. And then in these different tissues, we can look at different mechanisms, cell mechanisms. So for example, the mitochondria, etc.
Right, thank you. Pascale, I have a question of maybe you can answer from your cohort of 21 patients. Have you seen infantile or neonatal presentation of TANGO2 deficiency?
The severe boy I discussed in the talk was very sick at 4 months of age. The mother is very nice, and she described a normal baby at birth, but not acute event. So probably he was very severe in the first week of life, but progressively, probably, but at 4 months he was encephalopathic.
All right, thank you.
And after the other diagnoses were later for the other patients.
All right, thank you. Oh, and one more question is, in your experience with your 21 patients, and you talk about the milder symptoms, is anyone almost completely typically developing normal in every other way, but has a diagnosis of TANGO2 by testing?
So the question is for the normal patients or for the fasting?
No, so any patient in your mildest presentation that you've had, have you had a patient who has extremely minimal like presentation or symptoms of TANGO patients?
Yes, but we know I don't know what we will say, all other physicians, but we know it's a mystery. We know a lot of metabolic disease and genetic disease with very huge variability between siblings. And we don't have one explanation for that. And we hope that the normal child at 3 years will not have acute decompensations after a fever or gastroenteritis, okay? But she needed to go to the school and to build his immune system. So she will not live at home, of course. It will not be good. But we know this variability, and we don't have any explanation because we have no correlation between gene and the phenotype. Do you want to add something?
I agree that we have not seen any correlation between the mutation and the phenotype, but definitely within families we've seen variability if multiple children are affected, and we don't understand that well yet.
And I see another question on the fasting. It's a good question. When you had the sister, which is normal at 3, at birth, we had the diagnosis, and we recommended to the parents not to have a fasting for this child. So we did like fatty acid oxidation, a meal every 4 hours in the first months of age, and after we between all the 6 hours, etc. And but now she's fasting 12 with no problem. So we don't have any other recommendation. We don't give cornstarch, for example, but of course immediate glucose infusion when she is vomiting, diarrhea, and when she doesn't want to eat.
Thank you. Mike is asking if the anesthetics to be avoided or whether they should be in the emergency protocol, or is it published that these anesthetics particularly should be avoided?
Yes. So in France, I coordinate the French network of reference centers of metabolic disease. We have 100 reference centers. So we publish now homogeneous certificates. We do with all the physicians. Every month we have a meeting, and we will translate this this protocol in English, of course, but probably we will need to go this protocol of TANGO2 deficiency with the foundation all together. And and it's very important the patients to understand that the certificate is not a protocol. It will be modified with the time because we will understand better the mechanism of the disease.
Okay.
Yes, of
before I take more questions, I wanted to ask Kara, how are we doing on timing?
We're doing great on time. So we've got, I would say, another 10 minutes before break.
Okay. So we can take more questions. So from David, David is interested in some of Dr. Lonlay's other research, the clinical trial with hydroxychloroquine in the treatment of lipin-1 deficiency. And there are some similarities with TANGO2 deficiency. But the question is the study showing promise? Could it be a useful treatment for TANGO2 patients?
Thank you for the question. In lipin-1 disease, it's a disease with very severe rhabdomyolysis, but not other symptoms. So isolated acute rhabdomyolysis. We have lipin-1 protein, which is located in the late endosome in the cell, where is located the one receptor of virus, TLR9, so like receptor 9. So we have the combination of abnormal lipin-1 in the late endosome where the TLR9 is. And when we have a crisis, we have abnormal mitophagy and accumulation of mitochondrial DNA, which activate TLR9. So we have an inflammatory disease. So we treat now with a drug against inflammatory. So we give solimedrol corticoid. So maybe it can be a discussion for TANGO2 deficiency when we have a crisis with rhabdomyolysis, but maybe neurological symptoms, because I know that neurologists like a corticoid in a short time, of course, for the encephalopathy. So do we have to give a corticoid? In lipin-1, we have inflammatory disease. We know that. In TANGO2, we don't know if we have inflammatory disease. Of course, we are searching inflammatory disease to date, but we don't know. But why not to give steroid? We don't know during acute episodes. And for lipin-1, we are trying another treatment to prevent acute rhabdomyolysis, which is hydroxychloroquine against TLR9. But TANGO2 is not a disease of TLR9. So we will have to better understand the mechanism of TANGO2 to give appropriate treatment. It's too early, I think, now. It's not like lipin, but lipin, it was a good example of new gene with a nice treatment, probably because we understood the mechanism, but he took a lot of time to publish lipin-1.
Thank you. One question we have, and it's an interesting one. In zebrafish, how do you study intellectual disability?
In zebrafish?
In zebrafish, yes.
I can answer if you want, yeah. So for mental delays, yeah, you can do that on older zebrafish. So in adult zebrafish, you can assess the cognitive function. So, for example, social networking of the zebrafish. So this is definitely something that we can develop for TANGO2 disease. We can develop new tests also to assess this kind of question.
Right, thank you. Based on your experience on 22 patients, are there any drugs that can have a negative effect on TANGO2 metabolic side? And the answer and the question, whether antibiotics are harmful in some way?
So we spoke about the carnitine because I saw David Langman who said that maybe he has the same experience with the carnitine. So it's important to note that maybe a second patient didn't support carnitine. I don't know if David would like to say something. And after, we don't have any contraindication, maybe valproic acid because it's anti-epileptic. We don't like it for the mitochondrial disease, and so we don't want to give it. It inhibits a lot of energetic pathways, and glucagon in case of hypoglycemia because it will not treat the hypoglycemia, so it can be dangerous, and not other contraindication, I think.
Right, thank you.
And anesthetist, of course, anesthetist, some anesthetist.
Right. Another question is, for the two siblings that you mentioned with discordant phenotype, do they carry the same variant in TANGO2?
Yes. Yes, for the siblings, yes, of course, the same variant in TANGO2 because it was the same family, yes.
Right. And then do you feel that there can be decompensation with growth spurt, puberty in these patients?
I didn't understand.
Like, do they get more in trouble, more prone to metabolic crisis once they have a growth spurt? Like they have puberty, start of puberty. Have you seen that in your cohort or not necessarily?
No,
okay.
Not necessarily, no.
Okay, yeah, our experience is the same so far.
Okay.
Thank you.
Do we need to test to screen the siblings in a family? I think that it's an important question because probably we have to screen them because we can have a preventive action on the infection, probably to give a glucose infusion when they are sick. So probably we have to test the siblings. even if they are asymptomatic. Do you agree with that?
It depends. I would say yes. I also look at the age of the sibling. If the sibling is really young, then yes, I would do it, because you don't know when you'll see all the symptoms of TANGO2. So in a 1-year-old, 2-year-old sibling, I would definitely check the sibling.
Ils sont super en retard.
Ah bon?
Bah, 6. Attends, 2 secondes.
Right. We have 3 minutes, but we can go on break if there are no more questions. Kasha?
Okay. Thank you all. We have heard 3 presentations from 3 different countries so far. So this international collaboration is definitely amazing to see. I just want to remind everyone that you can click the thumbs up in the Q&A section if you see a question that you would like answered, and that helps us prioritize the questions that we ask our presenters. At this time, we are going to take a short break before introducing our next speaker, and we will be starting back up at 10:45 on Eastern Standard Time, which is in just over 5 minutes. So you can take a look at our next polling question when you rejoin us. See you shortly. Okay, it is 10:45 now. Welcome back, everyone. It is great to see so many different TANGO2 stakeholders joining us today. And it is very encouraging to see the collaborative efforts of so many families, doctors, and scientists as we work towards a better understanding of TANGO2 disease. Cara Cameron from Canada is a board and research committee member, as well as a TANGO2 parent, and she will introduce our next presenter. Cara?
Thanks, Kasha. Our next presenter was not able to attend this symposium today, but has pre-recorded his message and addressed many questions from families within his presentation. He is a professor in the biology department at Concordia University and an adjunct professor at McGill University in the Department of Anatomy and Cell Biology. His laboratory focuses on the mechanism of membrane transport between cellular compartments and diseases related to defects in this process. He has recently joined the board of directors for the TANGO2 Research Foundation. I am excited to introduce a fellow Canadian, Dr. Michael Sacher.
All right, so I'd like to thank the organizers for giving me the opportunity to talk to you today about some of the research we've been doing on the TANGO2 protein. Before I get into the talk, I'll just quickly tell you that I'm what my lab does. So I'm at the biology department at Concordia University, and my laboratory studies the mechanism by which proteins are transported between different compartments within a cell. And over the last 8 or so years, we've been focusing on genes whose proteins are involved in human disease. And that's a little bit of how I got involved in the TANGO2 project, but I'll discuss that in a little bit more detail shortly. So first, in terms of the layout of my talk, I'll give you a little bit of background, very general background in terms of parts of the cell that you'll need to understand in order to appreciate what I'm going to show you. I'll then talk about how the TANGO2 gene was initially discovered. For those of you who've been associated with the TANGO2 Foundation for a while, you probably know this. So this would be geared more towards those who are relatively new to the TANGO2 Foundation. And then I'll get into questions that we're trying to answer in terms of TANGO2 research, such as what does the TANGO2 protein look like? Where is it found in a cell? What kind of model systems can we use to address the function of the TANGO2 protein? And the question that we all really want to answer is, what does the TANGO2 protein actually do in a cell? And at the end, I'll wrap things up and tell you what exactly we're planning on doing as next steps. So I would ask you all to think back to your high school biology classes when you were told about different compartments in a cell. And there's only 4 that I'm going to ask you to dig out of the recesses of your mind. And that's, the first one is the endoplasmic reticulum, which I'm just going to call the ER, makes it simpler to talk about. There are proteins in the ER that need to get out of the ER, and they need to go to other compartments in the cell. And the first place that they're going to go after they leave the ER is the Golgi. You might know it as the Golgi apparatus, the Golgi complex. I'm simply going to call it the Golgi. Okay, so those are 2 compartments you need to know. The third one you're probably familiar with if you've been involved in the TANGO2 Foundation now, and that's the mitochondria. And we're told in our biology, high school biology classes, that the mitochondria are the powerhouses of the cell. And that's in fact the case. They can take the byproducts of metabolism of sugars, for example, and extract more energy out of them. They can take fatty acids and extract energy out of the fatty acids. And that brings me to the last compartment that you should know about for this talk, which is a lipid droplet. And a lipid droplet is an area in the cell where fatty acids reside. So the fatty acids are generally stored in molecules called triglycerides. Triglyceride is a glycerol molecule that has 3 fatty acids on it. And when the cell needs to derive energy from fatty acids, they can take the fatty acids out of lipid droplets in the form of triglycerides and take them off of the triglyceride and start metabolizing them. Okay, so my lab studies, as I mentioned, transport, and specifically we study transport between the ER, the endoplasmic reticulum, and the Golgi. And in the early 2000s, many of the proteins that are required to move proteins from the ER to the Golgi were known, but it was suspected that there were probably other proteins involved in this process as well. And so one particular group undertook what's called a genetic screen to try and find genes whose proteins are involved in either transporting proteins between the ER and the Golgi, or in just the organization of the Golgi, because the Golgi has a very distinct look to it in cells. And so out of this genetic screen, they found 20 genes, and they simply called them TANGO, which stood for transport and Golgi organization. So the genes encoded proteins that were either involved in moving proteins between the ER and the Golgi, or they somehow disrupted the look of the Golgi. It no longer looked as organized as it normally should. And so the genes were simply given the name TANGO. And so this is the table taken right out of their paper, and highlighted here is by the arrow is the TANGO2 gene. And what I think it's important to emphasize at this point is that these TANGO genes don't necessarily have anything to do with each other than the fact that they function between moving things between the ER and the Golgi, or in organizing the Golgi. And what I mean is, if we know the function of, say, TANGO1 or TANGO3 or TANGO4 or TANGO5, that doesn't mean that we're going to know the function of TANGO2. They share the name simply because of the screen that was performed in order to identify those genes. Okay, so one question that one might ask about any protein is, what does it look like? And why would we want to know what a protein looks like? Well, sometimes the shape of a protein, if it resembles another protein, and if that other protein's function is known, then we might be able to begin to speculate on the function of our protein of interest. Now, one thing my lab is doing is we're trying to purify sufficient amounts of the TANGO2 protein from different sources, from human cells, from insect cells, to try and determine what the protein looks like in 3 dimensions. Proteins are not simply a string of amino acids, they fold in 3 dimensions. And that's what we want to know, is what does it look like in 3 dimensions, and does that resemble some other protein? So we're still working on that, but just a few months ago, a paper was published that uses an algorithm to supposedly accurately show what the protein would look like. We still need to experimentally verify that, determine that. But putting the TANGO2 amino acid sequence into this algorithm gives us a protein that looks like this. So you see some curly areas here, some curly areas here spread around. Those are particular structures that proteins take, called alpha helix. We see some more flat regions here in brown and red, and some blue arrows here that align together to form maybe a sheet in the protein. That's essentially what it looks like, but unfortunately, it doesn't really tell us much about the function of TANGO2. Now, there are a number of TANGO2 mutations. Some of them prevent the protein from being made at all, common exon 3 to exon 9 deletion, for example. But there are some where an amino acid in the TANGO2 protein has been changed for a different amino acid. And those are the mutations in TANGO2, and some of those types of mutations can make the protein non-functional. So what I've done here is I've mapped 5 such mutations where just a single amino acid was changed, and we know that this is a mutation in the TANGO2 gene that affects its function because it's associated with disease. And what I thought was interesting here is you can see that how 4 of them seem to cluster in one particular region of the protein. Now, we don't know what the protein does, but ultimately, once we start understanding what it does, these mutations might may reveal something to us. And in fact, they may at this point highlight that this particular region of the protein has some sort of function. What that function is, we don't yet know, but we're moving our way towards answering that particular question. So now, how did I get involved in TANGO2 research? Well, we were studying a gene which was mutated in certain individuals that had a triggered form of rhabdomyolysis. Now, that might sound familiar to those of you with children affected by TANGO2 mutations, that there is rhabdomyolysis in individuals with TANGO2 mutations that is oftentimes triggered by something, by an illness, by change in diet. And that's a kind of a unique phenotype. And Felix Distelmaier in Germany saw our paper on this other gene that we had published about and made the connection that both of them seem to have this triggered rhabdomyolysis, the mutation in the gene that we're interested in a few years ago, and TANGO2. And so he got in touch with me and asked me, would we like to look at some cells from individuals that have TANGO2 mutations? Because our protein that we had originally studied was involved in transport between the ER and the Golgi. And so he speculated that TANGO2 might also be involved in that process. So gladly said yes, this is exactly what we do in my laboratory. And so I'm not going to get involved in the details of how we study the movement of proteins between the ER and the Golgi. So I just left it as a simple cartoon that I'll briefly describe here. So we look at a cargo molecule. That's a molecule that's going to leave the ER and go to the Golgi. And we make that cargo molecule fluorescent. And what that means is when we shine a particular type of light at that protein, it will give back a certain type of light. It will glow, basically. It will light up. And so we start our assay with that fluorescent cargo protein in the ER. So when we look at it under a microscope and we look at where is that lit up cargo molecule, we see that it's in the ER. And then we wait a little bit of time, we add a certain chemical to the mix. And after about 30 minutes, that cargo molecule makes its way to the Golgi. And again, we can follow that because that cargo molecule is lit up and we just follow where the light is going. It's going from the ER to the Golgi, and they both look different under a microscope, so we can easily tell them apart. And so we did that assay with cells that don't have a TANGO2 mutation and with cells that do have TANGO2 mutation. So shown here in this black line is the wild type cells, the cells that don't have a TANGO2 mutation. And what we're looking at is how much fluorescent protein, that light, gets into the Golgi over time. So you can see we waited about 40 minutes and we see a steady increase in the amount of that cargo getting into the Golgi. But when we looked at TANGO2 cells, this is just showing one of them for simplicity, but we looked at several others, and that's shown in blue. And you can see there's a delay in that accumulation of that light within the Golgi, of that cargo protein in the Golgi. And we know that this is due to a mutation in the TANGO2 gene in those cells, because when we add a wild type version of TANGO2, a version of TANGO2 that has no mutation in it, that's shown in red, then that accumulation of that cargo looks more like it does for the control cells. Okay, so that tells us that there is a delay in moving proteins between the ER and the Golgi in cells that have this particular TANGO2 mutation. And so we decided to take this a step further and let's find out where is the TANGO2 protein found in the cells. Very often proteins that function in transporting other proteins between the ER and the Golgi, very oftentimes they're found either at the ER or at the Golgi. That would make sense. So this is a bit of a complicated image here, so I'm going to walk you through it much more slowly now. What we did was we wanted to find out where TANGO2 was. So what we did was we made the TANGO2 protein fluorescent, just like I talked about on the previous slide. Now we made the TANGO2 protein fluorescent. We had a choice now. We could either put this fluorescent molecule at one end, the beginning of TANGO2, let's call it, or we could put it at the end of TANGO2. We didn't know which was the best place to put it, so we put it at both ends. That's why you see here TANGO2 RFP, and down here RFP TANGO2. Right? What RFP is doesn't matter. It's a fluorescent molecule that's stuck either at one end of TANGO2 or at the beginning of TANGO2. And now we're looking at a bunch of cells under the microscope, and we're shining light on them, and we're asking, where is the light coming back from TANGO2? That's going to tell us where the TANGO2 protein is. So here we see 1, 2, 3, 4, about 5 cells in this picture. The dark region is the nucleus, and the white is where the TANGO2 is. I am not showing you what the Golgi looks like in these types of cells, but you'll trust me when I tell you that that looks nothing like what the Golgi should look like, which was our first surprise because we completely expected it to look like either the Golgi or the ER. It also does not look like what the ER looks like in these cells. It reminded us of a previous project where we worked on the mitochondria. And so we had another protein, which is a protein found in mitochondria, and it itself was also fluorescent. So we put the fluorescent TANGO2 protein into cells that also had a fluorescent mitochondria protein. And now what you can see is when we look at both of them separately, and these are the same cells, they're just giving off different types of light. And so we can separate those two types of light. So the light given off by TANGO2 looks like this. The light given off by the mitochondria looks like this. They look very similar. And in fact, we can artificially color the light or the signal that we see for TANGO2 in red. We can artificially color the light or the signal that we see for the mitochondria in green. And when you overlay red and green, if they do overlay perfectly, you start to see yellow. And that's exactly what we're seeing over here. When we overlaid them together, we merged the two signals, artificially coloring them red and green. We now see a lot of yellow. This is just a higher magnification or a zoom of these two regions shown by the numbers 1 and 2, just to show you that there's a lot of yellow in these cells, suggesting then that the TANGO2 protein, at least when the fluorescent molecule that we put on it is at the end of the protein, is found in the mitochondria. Now, what happens when we have that fluorescent molecule at the other side of TANGO2, at the beginning of TANGO2? Looks, you can just, to the untrained eye, just compare these two boxes. They don't look anything like each other. This one just looks much more smoothly staining the entire cell. And when we, again, artificially overlaid the TANGO2 signal with the mitochondria, we just see red and green. We don't really see any yellow over here. So that suggested to us that, first of all, a portion of TANGO2 is found in the mitochondria. And it also suggested that there's something at the beginning of the TANGO2 protein that allows it to go to the mitochondria. Because when we blocked it with this fluorescent molecule, that version of TANGO2 didn't go to the mitochondria. But when we leave it unblocked, exposed, by putting our fluorescent molecule at the other end of TANGO2, it gets to the mitochondria. Okay, so now, so it's a little puzzling to us. Why is this was the first instance that we knew of for a mitochondrial protein that affects ER to Golgi transport. We hadn't seen that described before, so kind of piqued our curiosity. So now we decided to perform what we call a guilt by association assay, and that is the following. If we know what proteins TANGO2 interacts with, and we know the function of those interacting partners, then we might be able to speculate what the function of TANGO2 is. So how are we going to find these partners that TANGO2 might bind with? So again, just like we can put a fluorescent molecule onto TANGO2, we can put another molecule onto TANGO2, either at the beginning of the TANGO2 protein or the end of the TANGO2 protein. That's what's represented by this blue blob. And what does that blue blob do? Well, when a protein gets very close to TANGO2, that blue blob leaves a mark on that other protein. Okay, and now we can then break open the cells and fish out these proteins that have that special mark on them, and then identify what are these proteins that have this special mark. It must be a protein that gets very close to TANGO2. Otherwise, it wouldn't get that special mark on it. So now when we did this with TANGO2 and this other protein, this blue blob at the beginning of TANGO2, we did not find any transport proteins that came close enough to TANGO2 to get that special mark on them. And we didn't find any mitochondrial proteins. But when we moved that blue blob to the other end of TANGO2, then what did we see? Again, we did not see any transport proteins, any proteins that would suggest that TANGO2 is involved in ER to Golgi transport, but we did see a lot of mitochondrial proteins. Now, it's important to know that the mitochondria are very highly concentrated in proteins. So what do we make of this result? Well, it's similar to one getting on the subway at Grand Central Station during rush hour. You're packed in like sardines. You're going to bump up against a lot of other people. You've got nothing to do with them. So our interpretation of the fact that we started to see a lot of mitochondria proteins in this scenario is simply reinforcing the notion that TANGO2 is in the mitochondria. It's a crowded little subway there, and there's a lot of proteins banging around against each other. However, there were a couple of mitochondrial proteins that kind of stood out above the crowd to us. And one of them is a protein that's involved in releasing fatty acids from a molecule called coenzyme A, or I'll shorten it to CoA. So that's intriguing because it's increasingly suspected that TANGO2 may have something to do with fatty acid metabolism. And so it's interesting to find a protein that is involved in releasing fatty acids from this molecule CoA. Fatty acids are normally bound to CoA when they are metabolized and energy is being extracted from them. So we wanted to come up with a model system where we might be able to start testing some ideas that we have based on some of this data. And this is the model system that we settled upon. From up close here, it looks kind of disgusting, but if you zoom back, you all have seen this. This has all been in your kitchen. It's what the scientists refer to as Drosophila melanogaster, what we would all call fruit flies. You leave fruit on your counters for too long, these pesky little insects go flying around. They're impossible to catch. I have a foolproof method to catch them, and when we're in person, I'll be more than happy to share that method with you. But this is the model system that we're using. Why? They have almost as many genes as humans have. They have a TANGO2 gene, and we were able to get a colony of fruit flies that have a mutation in the TANGO2 gene. And so we started to study the effects of TANGO2 mutations on the fruit fly. And one of the things we did was to look at stresses on the fruit fly, because we know that the phenotype in TANGO2 patients is often triggered by stress of some sort, temperature, fever, illness, or starvation, or change in diet, I should say. So what we did was we started looking at some of the stresses. This is just one of them that I'm going to show you. We looked at just plain old starvation on the flies and how they react to being fasted, if forced fasting. And so we're looking at the percentage of survival over here on the y-axis over time. And in black, you can see wild type flies that have a wild type version of TANGO2. After about 3 days in the absence of food, they eventually all die off. But you can appreciate from this graph here that the TANGO2 mutant flies, shown in the red curve, die off much sooner than the wild type flies die off. And so putting together the notion that TANGO2 may have something to do with fatty acid metabolism and CoA, we wanted to now study what happens to what's happening during this drop-off in survival of the TANGO2 flies. And we thought we would look at the metabolism of triglycerides. Again, triglycerides are in lipid droplets. Fatty acids can be released from the triglycerides, incorporated into the mitochondria, bound to CoA, and metabolized to produce energy. So it seemed like a logical thing to look at is how they metabolize triglycerides. And that's what I'm showing in this experiment here. So this is preliminary data that we have, and still needs to be looked at more carefully, repeated many more times. But consistently, what we're seeing is the TANGO2 mutants have lower levels of triglycerides compared to the wild type. That's where these curves start. But what's more interesting, I think, in this experiment is the slope of the curves. So in black is the wild type. And what we looked at was, what level of triglyceride do they have when we start that starvation experiment at time 0, so to speak? And what level of triglyceride do they have at 17 hours? Let me back up one slide here. At about 17 hours, that's where the TANGO2 mutants really start to dramatically die off, whereas that doesn't happen with the wild type flies. So we looked at those 2 time points, and you can see that over that 17-hour period, about 50% of the triglycerides are metabolized in the wild type flies. Over that same time period, much less of the triglycerides are metabolized. The slope of that curve is much less. Maybe 10 to 15% of the triglycerides are metabolized over that period of time. So that's interesting. That's an interesting result that I'll tie back at the end, or come back to at the end. We also looked at one last assay that I'll show you, which I like to call the creepy crawly assay. Now, I call it the creepy crawly assay because this is showing you, this little cartoon, the life cycle of fruit flies. So they emerge from, they start with an egg. They go through 3 different larval phases, the last one being the 3rd instar larva, and that's what we're using in our experiment. These little larvae, you'd look at them and just think that they're maggots. And we pull them out of the tubes that we allow them to grow in. We stick them on the middle of a dish, and we watch how far they move over a given period of time. So we're looking here at how far did they move over a 9-minute period of time. You can see the wild type flies move about 13 centimeters over that period of time, but the TANGO2 mutants move much less over that same period of time. Again, that's consistent with a lack of energy in the TANGO2 mutants. Again, coming back to this notion that TANGO2 is somehow involved in energy production in the cells. So we're starting to formulate a hypothesis about what TANGO2 might do. And I should emphasize that this is a hypothesis. Hypotheses have to be proven correct or proven false. Many are proven false, many are proven correct. So we still need to do the experiments to prove it. But our hypothesis for the time being is that TANGO2 somehow is regulating the levels of cellular CoA. Again, remember, fatty acids need to bind to CoA. And if they're not bound to CoA, they're not going to be processed as efficiently for energy. Now, what I'm showing you here is how is coenzyme A or CoA made in a cell. And interestingly, it starts with pantothenic acid, which we also call vitamin B5. And there are a number of enzymes that function in this pathway to ultimately convert vitamin B5 into coenzyme A. So you might be looking at our hypothesis and this coenzyme A production pathway, or biosynthetic pathways we would call it, and you might say, well, what does that have to do with the transport defect that you showed us? It was quite a severe transport defect that we showed. Well, transporting material between the ER and the Golgi requires energy. Many other cellular pathways require energy. We've looked at another cellular pathway in the cell that is also defective in the TANGO2 mutant patients. We're also starting to look at a 3rd cellular pathway, which I suspect will also be defective in the TANGO2 mutant cells. Now, that either means that TANGO2 has its hands in many different pathways, which I don't personally believe, or TANGO2 does something that's required by all of these pathways. And what is required by all of these pathways is energy. So I believe that TANGO2 really does have something to do with production of energy in the cells under certain conditions. I don't believe it's required under all conditions. So under certain stresses, TANGO2 is going to be then required in order for the cell to produce enough energy to survive. So what are we going to be doing in the future? Well, we'd first like to verify this interaction between TANGO2 and this mitochondrial enzyme that we found that releases fatty acids from CoA. We want to see if we just take the purified TANGO2 and the purified mitochondrial enzyme, do they interact in any way? Does TANGO2 in that, what we would call an in vitro situation, in that purified system, does it affect the function of that mitochondrial enzyme? We're also going to look at cells that have mutations in TANGO2 to see what they do in terms of utilizing their fatty acids. We've suggested that there might be a defect in the ability of cells to metabolize triglycerides in lipid droplets based on our fruit fly work. We have some preliminary data suggesting that individuals with TANGO2 mutations, that cells from these individuals also have larger number of lipid droplets in their cells. So that might also be consistent with what we're seeing in the fruit flies. And going back to the fruit fly system, we're going to look at vitamin B5. If really the cellular levels of coenzyme A are an issue, we can try and force the cells to make more coenzyme A by simply feeding the fruit flies high amounts of vitamin B5. And then we can test whether that affects that survival curve that I showed you, whether they perform better on some of these energy assays, such as the movement from the center of that plate that I showed you. And we're also going to look at genetic interactions, because fruit fly is a very good genetic system. We can take flies that have mutations in TANGO2 and flies that have mutations in any of the genes that are involved in this biosynthetic pathway to coenzyme A. Oftentimes, when you combine two mutations in the same pathway, the result is a more severe phenotype than you would see for either of the individual mutations. So if we now generate fruit flies that have a mutation in TANGO2 and a mutation in one of these enzymes along this pathway, and those flies are even more sick than either of those individual mutations alone, that would also support the model that our hypothesis that TANGO2 is somehow involved in the production of coenzyme A in these cells. So that gives you a little flavor for what it is that we're doing in my lab in terms of addressing what the function of TANGO2 is. And I'll just finish by acknowledging those people in my lab who've contributed to the work that I showed today. Miroslav Milev is a research associate in my lab who performed the trafficking assay, the transport assay that I showed you, and did a lot of the work on localizing TANGO2 to the mitochondria. Elnaz Fatemi is a former student in the lab who did the assay of the guilt by association assay, finding this particular enzyme that might interact with TANGO2 in the mitochondria. And Priya Sadi is an undergraduate student in my lab, an excellent undergraduate student who has really set up the fruit fly system in my lab and has done all of the fruit fly work that I showed you. This work was started in collaboration with, the fruit fly work, I should say, was started in collaboration with Chiara Gamberi, who was in our department at the time and has since moved on to a faculty position in Coastal University in South Carolina. And Felix Distelmaier, I already mentioned, is a collaborator who initially introduced us to TANGO2 and provided us with the cells to get us going in this area of research. And funding for the work in my lab comes from the Canadian Institutes of Health Research, NSERC in Canada, Concordia University, and especially thankful to the TANGO2 Research Foundation for providing us with some funds to get a lot of this work off the ground. Thank you very much.
Thanks. Thank you very much to Dr. Sacher. We are very appreciative that he was able to take the time to record his message, even though he was unable to join us in person today. At this time, I just want to quickly show you our poll result that we did at break time. And you can see we've got 3 great groups here that make up a pretty amazing TANGO2 team. Here it is. There we go. Families, medical professionals, science professionals, researchers, and I know there's a few from the other category out there, especially friends and family. So thank you to the whole TANGO2 team out there. Okay. At this time, Blake Moore from Texas in the United States is he is a board member and a TANGO2 dad that will introduce our next presenter. Blake.
Thank you, Kasia. I'm happy to be part of this event today and proud to introduce our next speaker, Dr. Sam Mackenzie, from the University of Rochester in New York. He is a clinician scientist focused on gene-based therapies for neurogenetic diseases affecting children. He spends his time taking care of children with neuromuscular conditions and is also actively involved in basic science and translational research in the lab. He is also the newest member of the Foundation Research Committee. Dr. Mackenzie was not able to attend in person today, but has pre-recorded his presentation, incorporating many questions from families. Here's Dr. Mackenzie.
Well, good morning, good afternoon, good evening, wherever you are, and thanks for tuning in today. As was just stated, my name is Sam Mackenzie. I'm a pediatric neuromuscular doctor at the University of Rochester. And today I'm going to be talking about gene replacement therapy for TANGO2. And I don't have any disclosures directly relevant to this talk, but here's my involvement outside of my academic appointment. And I'm going to start with a little bit of background to provide some context for what we're going to be talking about today. Now, we commonly hear the term rare disease when we think about TANGO2, and that term has a strict definition. Specifically, a rare disease affects less than 1 in 2,000 individuals. And as all of you know, TANGO2 is much more rare than that and probably affects closer to 1 in a million people. But even using that 1 in a million number for context, when we add up all of the rare diseases out there, of which there are over 6,000, we can gain an appreciation that rare disease probably isn't so rare. So unfortunately, there aren't many treatments for rare diseases. But the good news is that there have been a lot of efforts to promote industry interest in this space. And in the US, for example, we have the Orphan Drug Act, which provides incentives for research and development, as well as longer patent protection for drugs developed for rare diseases. And we can parse rare diseases out further into rare disease brought on by genetic cause. When we think about rare disease being caused by a single gene, we call it monogenic. So these are just some of the terms that I think help lay the foundation. Now, there are about 20,000 genes in the human genome, and we have 2 copies of each one from each of our parents. And as many of you know, TANGO2 deficiency arises when there are 2 separate misspellings or missing pieces within that TANGO2 gene. And because it's involving both the copy that we got from our mother and our father, that mode of inheritance is called autosomal recessive. And because the results, this results in a lack of TANGO2 protein, we call conditions like these loss of function. So to summarize, TANGO2 deficiency syndrome is a rare, monogenic, autosomal recessive, loss of function condition, and no treatments currently exist for TANGO2. But that won't always be the case. And this leads me to the main topic of my talk. So it seems obvious that if there are problems within the TANGO2 gene, we should be able to replace it somehow. And in fact, we are trying to do this for a lot of other conditions at the present time. And we call this method gene replacement therapy. So how does this work? Let's see here. So with gene therapy, we basically use a stripped down version of a virus, which you can see here at the top. And this has all the bad parts of the virus removed. And we actually use a virus that doesn't cause diseases in humans in the first place. So the virus is really just a shell at this point, and we call that a capsid. And we place a gene of interest inside the virus, in this hypothetical case, the TANGO2 gene, into the capsid. And then we infuse trillions of these vector particles into a patient by an IV infusion. The vector is able to cross the cell membrane where it drops off its cargo, again, that's our gene, into the cell. The gene then moves through the cell into the nucleus. And one important thing to know is that with gene therapy, the gene that we're adding does not integrate with the rest of our DNA. And if it did, you could imagine that it could insert itself anywhere in our genome, and that could lead to other problems. But it doesn't do that. Instead, it just kind of sits there inside the nucleus. The DNA is then turned into another type of code called RNA, which is sort of an intermediate code before it's turned into protein outside of the nucleus in the, still within the cell, but outside of the nucleus in the cytoplasm. And the kicker is with TANGO2, while it probably plays some role in cellular metabolism, we don't know what the TANGO2 protein does. And while it would be nice to know this, it may not be critical to have a full understanding of this mechanism before we start thinking about gene replacement. So one example that I wanted to talk about briefly of another commercially available gene therapy is spinal muscular atrophy. And by the way, the SMN protein, which is implicated in spinal muscular atrophy, is still something we don't really understand. We just know that when the patient is missing this protein, the motor neurons in the spinal cord start to die off, leading to muscle weakness and respiratory failure. And like TANGO2, SMA is a rare monogenic loss of function condition. And we screen for this in the United States using what's called the newborn screen. And most of the time, if we're able to make this diagnosis after birth, parents will pursue gene therapy for their children. So before gene therapy, even when I was in medical school, which wasn't too long ago, infants with the more severe form of SMA would typically die on a ventilator around age 2. And this graph highlights children treated with gene therapy and shows improvement in their gross motor function here, which is on the y-axis by way of CHOP and 10 score. That's just a measurement tool for motor function. And you can see that these scores go up after children were treated with gene therapy. Now, the caveat here, if you compare this group to these groups, which got therapy later, they do better if they're treated earlier. And we know now that the earlier we get the gene therapy into these patients, the better they do in the long run. And in SMA, that's probably because once these motor neurons die, we don't have a way to bring them back. So we've talked about placing a gene into a viral shell, and I think that conceptually makes sense for a lot of people. A few caveats, though. Different viruses go to different cells within the body. So you can imagine that for TANGO2, we'd want a virus that successfully delivers its cargo to muscle, to brain, to heart, to liver at the very least. And several viruses actually do this. So that's good news. Second, once a gene is delivered, we need to think about how to turn that gene on. And promoters are sequences of non-coding protein DNA that do this in different cell types. There's also other regulatory elements called enhancers that get the expression levels to increase if they're present as well in that construct. So all of these things need to fit into the virus, and we need to think about how much the virus can hold. And for AAV9, it's 4,700 base pairs of DNA. And that's just the way of measuring how long it is. And the good news is that with TANGO2, the gene coding region of the gene, or the protein coding region of the gene, excuse me, is only about 1,000 base pairs long. If we add the untranslated region, it's 3,500 base pairs long. So that still leaves a bit of room for promoters and enhancers, things like that, if we were to develop a construct. And I haven't spoken a lot about safety, but it's obviously a critical aspect that we consider when it comes to gene therapy for TANGO2 or really any other disease. And a special consideration we have to think about for TANGO2 is that we don't want an immune response to come up when patients receive this viral particle. And I say that because obviously metabolic crises are things we want to avoid in TANGO2. Getting the virus to all the cells that need it might be a tough proposition. And ideally, just like SMA, we want to intervene before kids show symptoms of the disease, really. And with TANGO2, we unfortunately don't make the diagnosis until after some sort of symptoms have started. So that really poses a challenge and makes us think about how we can get TANGO2 diagnosed earlier. The good news here is that, while it's still after symptom onset, the Research Foundation has been working very hard to get TANGO2 on more gene panels to achieve earlier diagnoses in patients with the condition. And those gene panels might be things like rhabdomyolysis, metabolic crisis, cardiac arrhythmia, cardiomyopathy, seizures, and also ataxia. So how do we know gene therapy is effective? If we had a gene therapy, hypothetically, how do we know that it works? Well, that requires clinical trials. And before we have a clinical trial, we need to know where the goalpost is. So what are the outcomes of the condition if it's left untreated? And what outcomes might we improve with a gene therapy or any other therapy? And this is a challenge that actually requires quite a lot of thought when it comes to TANGO2, since as you know, the presentations can be so different. There's a cost consideration too. So Zolgensma, which is the drug for SMA, costs $2.2 million for a one-time treatment. And that's a whole talk in and of itself, which I'm not going to get into today. But this just speaks to the fact that research and development of gene therapy is also expensive. Getting back to the clinical trial question for a second, how do we get there? So this is just kind of a rough research roadmap of any disease, and it might apply to TANGO2. So I can walk you through it. So it starts with, retrospective studies of patients. The condition was discovered in 2016, and there have since been several series of patients out of the United States and Europe that basically provide an account of the symptoms that these children have had, what the misspelling or the missing piece in the TANGO2 gene has been. And these have been super informative. And I just want to thank you. If your child was part of these studies, it's really important for us to understand how this disease is working. And kind of moving down on this left column here for just a moment, from there, we think about natural history studies. And this is just a more systematic way to characterize these symptoms that we see in the disease. And once we understand the symptoms, we can think about outcome measures. And these are things that might be reversed or improved with the therapy. Now, once we have outcome measures, then we can get into clinical trials and testing a therapeutic compound. Finally, once a compound is approved, we think about long-term follow-up studies to make sure that the safety and efficacy profiles hold up in the long term. So on this parallel right column here, we have these series of patients that we know, it gives us clues as to what might be going on. So understanding these disease mechanisms at a cellular level is a lot of a big part of the process. So what is the TANGO2 protein doing in cells? And that leads us into developing animal models to also develop these disease mechanisms. And once we have animal models and good cell culture models, we can test therapeutic compounds preclinically before they advance to clinical trials. So all of these things need to happen. And in terms of what's been done, the retrospective studies, as I alluded to, we now have several, and there was just another case series published out of a group at Stanford. So it brings us close to 100 patients in the literature. And we've learned a lot from those. These are the steps that are kind of underway, a lot of these funded by the TANGO2 Research Foundation, including the natural history study through Baylor. And here's a step that I would posit today. It's not too early to start thinking about. So before we get to clinical trials, even though we don't have a therapy that we want to test yet, we want to be ready when such a therapy comes on board. So that outcome measure development is something that we can probably start to think about in the next few years. And then, with the therapeutic development, I didn't even put that on here. So a big question is, how do we develop a drug in the first place, right? So just a day before I recorded this talk, Anne, Mike, Kasha, and I met with the coordinator for the NGLY1 deficiency group, which is called GRACE Science. And they have, this is a rare disease. So NGLY1 is a gene that's implicated in developmental regression, epilepsy, and it's probably more rare than TANGO2. So we think there's less than 100 kids with NGLY1 deficiency. And I'll talk about what's commercially viable in terms of how many patients you need before industry interest is developed in developing a gene therapy or other therapeutic compound. But because this disease is so rare, they've actually funded their own LLC and committed dollars towards the development of a gene therapy to develop kind of in-house. So that's one model. Another model is something like what's happening now through the NIH, and this is an initiative called the Bespoke Gene Therapy Consortium that you can look it up online. This is several NIH institutes. And the idea with this is that we now have this platform where we use AAV9 as a viral vector. It was successful in SMA. We know which cells it goes to. We know the safety profile more or less, but it's going to be a little bit dependent on the condition you want to treat. Still, if we're just swapping out what's inside that viral shell, you can imagine we don't want to be reinventing the wheel every time we do a clinical trial. So this initiative, a lot of it is streamlining the regulatory processes on the front end and making it easier for these clinical trials to advance quickly while maintaining all the safeguards that we know we need to think about when we're talking about gene therapy. And the last model that I'll talk about is just going straight through industry. And I've alluded to this. So if a disease is so rare that there's maybe less than 100 patients that would be treated per year, it might not make sense from a dollar standpoint for a company to spend the money on research and development if they can't recoup it on the back end. Similarly, for a lot more patients in a given disease state, it might not be able to be scaled in such a way that it makes sense to develop the gene therapy. So the sweet spot is sort of in the middle here, where there's 100 to 10,000 or so patients, and this is where TANGO2 lives. So we just had this these data come back from the Broad Institute a few months ago. They looked at all of the pathogenic alleles, meaning the misspellings in the TANGO2 gene that are reported in population databases. And based on that, estimated that there are about 6,000 patients, and this is a conservative estimate, worldwide with TANGO2 disease. And I will say that this is probably, or almost definitely, I'll say, a underestimation, because these population databases are heavily biased by European genomes. So patients from European descent have their DNA analyzed, and we get the misspellings and all those variants from that population. So it probably underestimates the frequency of pathogenic variants in other groups, such as South America, Africa, Middle East, etc. So how do we approach patient heterogeneity when it comes to clinical outcome measures? This was a figure from a paper that was published by our group, just kind of highlighting all of the heterogeneous symptoms that might arise in TANGO2. And you can see that most kids are going to have cognitive impairment and motor speech delay. My guess is that the patients that didn't have this were probably too young to really make that assessment. I think this is almost universal in this condition. Not everybody has rhabdomyolysis and metabolic crises, but about 4 out of 5 will. And then about half will have seizures or different types of movement disorders. And so you can see here, this is just really tricky when it comes to thinking about how you would measure the disease and the improvement with a therapeutic compound, because not every patient is the same. And this complicates clinical trials. So how do we identify and track kids with different sets of symptoms? Is there a role for a kind of modular outcome measure development, as well as a modular therapy development? So let's think about this in terms of a schema. If we think about survival and quality of life as kind of the core measures, you could imagine that we might have other assessments that incorporate cardiac function, neurological symptoms, et cetera. And some patients may just have the cognitive impairment and gross motor delay, while others might have everything except cardiac involvement, while still others may have more cardiac involvement, but less of the but not have seizures or ataxia, et cetera. So I think there are ways to get around this problem. So in conclusion, gene therapy is theoretically a viable option, though it's not the only option for TANGO2 disease, given that this is a monogenic autosomal recessive loss of function condition with a small gene that could fit into a viral vector. We still need to learn a lot about disease mechanisms, but this may not be, a limitation before we think about therapeutic development. And we still need good animal models and a phenotype or biomarker of some kind that we can reverse with a therapeutic compound. Safety is a big consideration, especially with the risk of metabolic crises. And with all of these therapies, they're very expensive. We'll probably want to partner with an industry partner at some point. Not too early to think about clinical outcome measures and clinical trial readiness. And finally, in terms of equity, I think we really need to do a better job at improving diagnosis rates to ensure that every kid that is diagnosed with this disease is able to receive treatment. So I will segue that into a plea to sign up for the natural history study and the CORDS registry. These are really critical steps that we need to take before we can develop a treatment. And I will close with that. And here's my email and my Twitter handle should you have any questions related to the talk. Be happy to hear from you. Thanks so much.
All right, so I'm happy to report that Dr. Mackenzie is also was able to join the symposium. So we can take questions. We have a few minutes before the next speaker. I'll start with Mike's question for Sam. Mike says, it seems the mechanism for applying gene therapy is becoming well established. Are the challenges on a per gene, per disease basis mainly around finding the appropriate vector and promoter mix, or are specific genes more receptive to gene replacement therapy in general?
Great question. So all of the above is the short answer. So we have, if you take Bespoke as an example, the real goal of that initiative is to streamline the early regulatory process. So making things like the IND pathway a lot less burdensome and cumbersome and expensive. So the whole goal of that, the thought process of that initiative is really to make it so you can kind of swap out whatever gene of interest you have. On the promoter end, it's a little bit tricky because a lot of the gene therapies I'm familiar with and involved with, we just want to target muscle or muscle and heart. And we have pretty established promoters for doing that. I think it's trickier when you think about getting gene expression in the CNS, in muscle, in all these different tissues. So the promoter question is important. And the last thing I'll say is we don't want to overshoot. So we don't know if, making too much TANGO2 might be toxic. So I think there's a lot of work to do in making sure we kind of hit the sweet spot with gene expression. It would definitely be its own body of work, I think, to develop a gene therapy for TANGO2, but not something that's insurmountable.
Thank you, Sam. Another question is from our previously submitted questions. So one of them is there a medication that can stabilize the neurological symptoms of children?
Yeah, and I caught the end of Dr. Sacher's talk, and a lot of providers have anecdotally, I know, prescribed mitochondrial cocktails, and you're probably among them, Seema. But the B vitamin complexes, I can say anecdotally, I don't intend this as medical advice, but seem to be beneficial. Things that kind of promote the breakdown of fats, so levocarnitine, although, I think in the study out of France that may have been associated with arrhythmia in one patient. So we just don't know. I think there are some hints with the disease that, mitochondrial function is impaired, and we do have some things that kind of mitigate that. Nothing is curative at this point. So, but I think that's absolutely a more low-hanging fruit than gene therapy in the near term is to figure out which ones of these compounds may help slow the disease course.
And I'll just do one last question. Is this something which is for in the newborn period gene therapy, or you think that it can be applicable to older kids?
Well, from the SMA cases that we know, the children, as I said, that get treated earliest do the best. Sometimes we're treating kids as early as a week of age, and that's because we have those results back on the newborn screen. Obviously, that's not going to be something that's available for TANGO2 unless we have a family with one affected child and they want to do the screening in a sibling. So we may make that diagnosis in the pre-symptomatic period. I think from what we know from other diseases, earlier is better. But we're doing a gene therapy trial in Duchenne muscular dystrophy where we're treating boys between the ages of 4 and 7. So it's not something that necessarily has to happen as a newborn.
All right. Thank you so much, Sam. I think we'll stop here and take the next speaker. Thank you.
Great, thanks.
Many thanks to Dr. Mackenzie. And I just want to point out, I think it's pretty amazing that we have had 5 speakers and they have been from 5 different countries. Next up is a board member and TANGO2 mom, Veronica Jones from California in the United States, who will introduce our next presenter. Veronica.
Hi, everyone. Dr. Lina Gonzalez is an assistant professor of pediatrics in the Division of Genetics and Medical Genomics at University of Pittsburgh. She is board certified in internal medicine, medical genetics and genomics, and medical biochemical genetics. It's my pleasure to welcome Dr. Gonzalez.
I think you're muted, Lina.
You can hear me now?
Yes, thank you.
Okay, sorry for that. Hi, everyone. Thank you for giving me the opportunity to speak here at the symposium, and thank you for the TANGO2 Foundation for the grant that supported this work that I'll be presenting. So my talk today will be about mitochondrial dysfunction associated with TANGO2 deficiency. So a little bit of background, even though by now you had a lot of introduction by the other speakers. So TANGO2, as you know, stands for the Transport and Golgi Organization 2 homolog. We still don't know the exact function of the TANGO2, but there are studies that looked into the mitochondria. And as you know, the mitochondria is the powerhouse of the cell. Because of the previous investigations of the mitochondria, some discrepancies, we decided to look more in depth into the what's happening in the mitochondria and its function. So before we started the work, we wanted to see where is TANGO2 expressed. And if you look at the TANGO2 expression, you see that it is expressed in most of the tissues. And that was good because we were doing the functional studies in the skin fibroblasts. And as you can see here, TANGO2 is expressed in the skin. Pathophysiology of the disease, we know some, but we really don't know the exact function of the TANGO2, as you know by the different presentations so far. So this is what we know so far. There was a original publication where they showed T10, which is a TANGO2 homolog protein in mice. It was expressed robustly in the mitochondria in the brain of the mice. There are different abnormalities shown in the metabolic labs in patients. Some of these abnormalities are similar to what we usually see in mitochondrial disorders. So some of the patients have abnormal AC carotene profile. The interesting thing is that these patients don't have the exact pattern. So some of them have similar pattern to CPT2 deficiency, others similar to VLCAD deficiency. There are some even with elevated C3, which we see with the propionic acidemia, and some patients have completely normal acyl-carotene profile. Other abnormalities that we see is episodic rhabdomyolysis that happened in not all the patients, but many patients, hypoglycemia, hyperammonemia, which is high ammonia, and severe metabolic acidosis, like with elevated lactate. And also some reported abnormalities were reported in the mitochondrial complexes, which there are 5 complexes of mitochondria, 1 to 5, but there are reported abnormalities in 4 of these complexes. So all of these changes that we're seeing here, and just with the metabolic labs, we see in general in patients with mitochondrial diseases. There are different studies suggesting changes in proteins that they are involved in different networks, and some of these networks are inside of the mitochondria. So lots of discrepancies, and I will be showing here the 2 most recent studies. One of them was done in the skin fibroblast, where in that study, they showed that the number of the mitochondria was increased and they were smaller in size. And they showed in that study that the TANGO2 was partly localized into the mitochondria. While about almost the same time, there was another study, but that was done in the primary myoblasts, like the muscle cells. And in that, they didn't see change in the mitochondrial morphology, like increase in number or in the size of the mitochondria. And there was studies in the primary myoblasts showing that there was the oxygen consumption rate was normal in most patients. So very different, perspectives and results for involvement of mitochondria in TANGO2 deficiency. And because of that, we went ahead and wanted to see, okay, what is really happening in the mitochondria. So we started with the skin fibroblast functional studies, and here I have a table with the cells that they were used from the patients. So you can see P1, P2, these were patients here followed at UPMC Children's Hospital. So they are sibling, both of them have the homozygous deletion of exons 3 to 9. P2 unfortunately passed away at 6 years of age. He had severe lactic acidosis. P1 is a patient, she's currently 17 years of age, and she has profound developmental delay, failure to thrive, hypotonia, which is a low muscle tone, intractable seizures. She has dysphagia, which is difficulty with swallowing, and a generalized brain volume loss in the MRI. P3 is actually a patient that we got the skin fibroblast from a collaborator, and that patient is the least affected, is mildly affected compared with P1 and P2. Has 2 different mutations. One of them is the common deletion of exon 3 to 9, and the other one is a splice site mutation. So also this you expect to have, deletion of the whole protein, but interestingly, patient is mildly affected compared with the others. She has mild global developmental delay, complex partial seizures, but they are under good control. And she had acute episode of rhabdomyolysis, lactic acidosis, and hypoglycemia, but I believe she only had one of these acute episodes only. And she is currently 7 years of age. So first, we wanted to see whether TANGO2 exists in the mitochondria or not. And the way to do this, we did Western blotting, which looks for protein of the TANGO2. And as you can see here on the right side, we did whole cell lysate. So you extract the protein from the whole cell, and you look for the TANGO2 protein, so wild type or the control, and here we have the patients. And as expected, we don't see TANGO2 in the patients because they have these big deletions of the gene. And GAPDH is just a control, and for our experiment to make sure that we are doing the experiment correctly. And these have to be equal or very almost equal. So this is telling us just the TANGO2 is in the control, it's not in the patients, but we wanted to see whether the TANGO2 is inside of the mitochondria. And in order to do this, we extracted only the mitochondria from the cells. And we did the same experiment, like doing the Western blotting, and used the TANGO2. And we've seen in the mitochondrial extract that the TANGO2 was inside of the control. Of course, we won't see it in the patients just because it is deleted, but we were able to see it in the control in the mitochondrial extract. So that was okay, then it is in the mitochondria. So the next step, we wanted to look at the what's going on with the function of the mitochondria. So this is one of the experiments that we did, looking at what we call mitochondrial respiration. So this is a set of metabolic reactions that require oxygen, takes place into the mitochondria in order to get energy in the form of the ATP. So there are three different measurements that we do for the mitochondrial respiration or the oxygen consumption. First one is basal respiration. So we look at oxygen consumption inside of the mitochondria at rest. Maximal respiration is measures oxygen consumption of the mitochondria, but at maximal capacity. And the spare capacity is actually the difference between both the basal and the maximal respiration. We did this study under two different conditions, with glucose, so that means the cells were happy, not under stress, and without glucose, meaning we are stressing the cells, so to mimic what usually happens in the kids with TANGO2 during illness. So this is the results, and I will be showing the graphs. So with glucose or no stress, so when we have in the media where we have the cells, there was glucose. So we found that basal and maximal respiration and the spare capacity were similar between control and P3. So P3 is the least affected patient, while it was decreased in P1 and P2. With no glucose or under stress, all these three measures were decreased in patients compared to the control. So this is here a figure to visualize it easier. So this is how the experiment is done. We do plate the cells into a 96 well plate, and we put it in a machine called the seahorse instrument. And we do different injections for different compounds. We're able to measure the basal respiration, and then with the different injections that we do, especially here with the FCCP injection, we are forcing the mitochondria to consume oxygen at maximal capacity, and you can see the increase here. So we can measure with this the maximal respiration. And then the reserve capacity is usually what we get between this maximal respiration and the basal respiration. And if you see this here with this figure, so this is with glucose, wild type, which is the control, and P3 is the mildly affected patient. You can see how these almost overlap. So P3 is really doing good compared to the P1 and P2. P1 and P2, you can see that there is decrease in the basal respiration, the maximal respiration for both of them, and of course the spare capacity. P2 is the diseased individual, so he's the more severe, and this correlated actually with the clinical phenotype of the patients. So when we are putting the cells under stress with no glucose, and that's what happened when these kids are sick, we are seeing that even P3 that is mildly affected, it does not do well under stress or illness in the case of the kids. And it is, we see the basal respiration and maximal respiration, and of course the reserve capacity of the mitochondria is decreased compared with the control. This is the same data, but a different way of visualizing it. Some people might see this is easier to see. And this side here is with glucose, and this one is with no glucose or stress. So with the glucose here, we're looking again, basal respiration, maximal, and spare capacity. And what you need to look here is when we are comparing P3, the mildly affected, to the control, is really the same, doing really well compared with the control with no stress for all three measurements, while P1 and P2 is decreased in all. And interestingly, P2, the most severe affected patient, have the worst basal, maximal, and spare capacity. Here with the no glucose, as we've seen with the previous figure, you can see, P3 now is decreased for basal respiration, maximal, and spare capacity when we are comparing to the control. So, we saw that one, said, okay, well, let's look at the mitochondrial function in a different way. And we looked at the ATP production, and we know that ATP are molecules of energy, that they are fuel for the, and which is important for the different functions of the cell. We have ATP that comes from glycolysis, which is from the glucose metabolism pathway. And then also there is ATP that is produced from the mitochondria. And we know that most of the ATP that is produced is mostly from the mitochondria. So we looked at the ATP production by ATP rate assay with the same instrument, the seahorse. And with glucose, with no stress, we found that patients rely more on glycolysis, like getting the ATP from glucose rather than from the mitochondria. With no glucose or under stress, because there is no glucose there to get the glycolysis and the ATP, then we are seeing that, these mitochondria in the patients are working really hard to produce more ATP when we compare it to the with glucose. So here is, so you can see, these are the three different measurements that we can see. So this one here is the ATP that is produced from glycolysis, this in the middle from the mitochondria, and the total ATP is the combination of ATP produced from glycolysis and mitochondria. And you can see that patients really rely more on glycolysis, getting the ATP from the glucose metabolism pathway, and it is increased compared with the control. While you see here that mitochondrial ATP production was similar in P3 compared to the control, while it was decreased in P1 and P2. So they're not able to produce as much as ATP compared to the control from the mitochondria. But if you put these two together, because they are compensating by getting more ATP from glycolysis, yes, this is decreased here. So you are seeing here in this third figure that the ATP produced in these patients is about the same or even a little bit higher in the P1 and P3. So we wanted to say, okay, this is unexpected. Let's look at this in a different way. This is a continuation of the same experiment. When we did with no glucose, so this here, the no glucose is the red and the glucose is green, and we compared each with and without glucose with each cell line. And as expected, if you don't have glucose, there is no glycolysis, and the ATP production decreased in the everyone, even the control. So this is expected here. What we've seen here, which was interesting, that with no glucose, the ATP production from the mitochondria increases even in the control, but also P1 and P2, they're trying really to work hard and get that ATP produced from the mitochondria when there is no other source of getting the ATP from the glucose. So under that condition, the mitochondria, it seems that is able to produce the ATP. And then when we are looking at the total ATP production, we are seeing not much differences with and without glucose, so compared to the control. So, okay, so we looked at this, okay, this is unexpected. Let's look at it in a different way. So this one here is the one that I just showed you, that patients are able to keep up with the ATP production. So this is the total ATP. But then here on the right side, this is a different way of looking at the ATP, the net ATP, and that is by experiment called ATP light assay. So this is a luciferase assay, and there is a fluorescence binds to the ATP and gives us how much ATP is in the cells right now. So this is the net ATP, or the content of the ATP in the cells. So you can see here that the ATP in the cells is decreased in all three patients compared to the control, even with P3, the least affected one. So with this slide here, what we can, the conclusion that we got is that patients with TANGO2, they are able to get ATP production some way or the other. When they are not under stress, they are relying more on producing ATP from glycolysis. When they are, when there is no glucose, so their mitochondria is able to produce more ATP. But at the end, these patients are using their ATP faster than the control. So the left out ATP in the cells is less compared to the control. So looking more into other mitochondrial dynamics, we looked at the, here in this figure, you see that this is a figure of one mitochondria. As you know, each cell have hundreds to thousands of mitochondria. And then each mitochondria have tens to hundreds of mitochondrial DNA. And the mitochondrial DNA is as a ring DNA. So what we looked at is we wanted to see, okay, what's happening with the mitochondrial DNA content in this mitochondria. And what we've seen is that the number of DNA copies in each mitochondrion is decreased in patients. So they're not empty, but they have less DNA than what we usually see. And then the number of mitochondria in general is increased, and they are smaller in size in patients compared to the control. So when we see increase in the number of mitochondria, and they're smaller in size, meaning they are dividing faster, is a way to try to compensate for the abnormal function of the mitochondria. So in this figure here, this is what we did using TOM20, which is a marker in the mitochondrial membrane. By looking at these figures, you really cannot tell a difference of these. But when we do the analysis for the TOM20, which is on the mitochondrial membrane, we are trying to analyze the total volume of the mitochondria, the amount of the mitochondria in the cells. And by doing the analysis on these figures, you can see that number of mitochondria per cell in the patients is increased compared with the control. But the average volume of the mitochondrion, of each mitochondria, is smaller in size. So when we are seeing increase in the number of mitochondria, but they're really smaller in size. So another way of to support this is to look at fission and fusion. And fission is the way that mitochondria divide to make other mitochondria. And you can see here that from the control and patients. So this is a marker for the fission, and this is just a control to make sure that we're doing the experiment correctly. So we're looking at this here. You can see that there is increase in the intensity of the DRP1, which is the marker, one of the markers for fission. increase in P1, P2, and P3, mostly in the P2, the most affected. So that means like, you know, the mitochondria is dividing more than the normal control. Fusion is the other function of the mitochondria, where the mitochondria is connected to each other to make these networks. And we did test for 3 different markers. We didn't see very obvious change in that. Oops. So, this work was done by Dr. Eric Kolpis, works with us with the lab, a postdoc, and he next step was to look at the mitochondrial DNA copy numbers. So with these experiments, what we did is to look for nuclear gene that is in the nucleus. So it's genomic DNA, and also compared to mitochondrial DNA. So we did 2 different sets of mitochondrial and genomic DNA in these 2. So these are slightly different. So if you can, which is expected because they are different genes. But what you can tell from this is that the mitochondrial genomic copy number compared to the control, so the number of the DNA, mitochondrial DNA in the mitochondria, here is about the same in P1, P2, and a little bit increased in P3. P2 here was about the same, these were increased. However, if you take this into account with the previous slide where we've shown that the number of mitochondria is increased, so this does not correlate with the increase of the mitochondria. So if you take ratios of those, you can tell that the number of mitochondrial DNA copy number in each mitochondria is less, just because it's not increasing to the same degree as the number of mitochondria. So what does this mean for a TANGO2 child? So during illness, TANGO2, which this is happening already and many of the providers are doing, a TANGO2 child might benefit from getting more energy from IV fluids containing glucose because they really rely on their glycolysis. They try to work their mitochondria hard, but you know, giving this extra glucose will help them. TANGO2 kids might benefit from getting mitochondrial supplements. Yes, there is not much, it's not even much evidence in other mitochondrial diseases. All the information about mitochondrial supplements in mitochondrial disorders in general have weak evidence, except for very few of them, but they are used in many cases. We know the P3, the least affected patient, is on CoQ10, she's on levocarnitine, she's also on riboflavin and B50. I know there was some mention about the levocarnitine, it might cause arrhythmias, but I don't think we have much evidence also about that. And we still don't know the mechanism that leads to the mitochondrial dysfunction. We think that these changes that we are seeing are secondary mitochondrial abnormalities that we are seeing. It's not because of primary mitochondrial disease. So more studies has to be done to look at the real causes of leading to this mitochondrial dysfunction. And with that, I would like to acknowledge everyone that participated in ideas for this. So we have the TANGO2 Foundation, which supported this work, and I'm very grateful for that. So that was co-PI with Dr. Jerry Vockley, Paige Hyman. She was undergrad when she started. Now she started the med school, but she put a lot of effort of the TANGO2, and she always said TANGO2 is my baby. So she really was all about like doing work and research with the TANGO2. And Alyssa Powers, she's my new lab tech transitioning to PhD. She will be working on the TANGO2. To understand more the pathophysiology of the disease. Everyone in my lab and Dr. Vockley, you know, we always share ideas and we always learn from each other for sure. And I'm happy to take any questions.
Thank you, Lina. And please feel free to ask questions. So Lina, again, I just wanted to ask this, and I know you probably mentioned it, but the fact that the mitochondria are more and they are smaller, that you see that in other disorders too, right? Where the mitochondria appear to be stressed. Is that fair to say?
Stressed, or it's a way of compensation because if there is mitochondrial dysfunction to, they compensate by increasing the number of the mitochondria. So yes.
All right.
However, I mean, we show that the DNA content of this the DNA content of the mitochondrial DNA content in this mitochondria is less compared with the control. So there are copies of the mitochondrial DNA, but they are not as what it is in the control patients.
Thank you. I have an interesting question from Mike. So since we know that TANGO2 kids rely more on glycolysis when under stress, are there any supplements that promote more efficient glycolysis? Or is the main thing to increase supply, which would be glucose?
It will be increase the supply, which is increase the glucose. There is no supplements, to my knowledge, that increase the glycolysis pathway to get more ATP. And that's what we do actually in many of the metabolic disorders that we see. It's an easy way, and it was interesting to see that these patients, anyway, they are relying more on glycolysis to produce that ATP.
Great, thank you. Are there any known side effects to long-term dependence of glycolysis rather than mitochondrial metabolism? Could this be associated with some of the neurodegenerative aspects of T2?
I won't say that there would be known long-term effects of relying on glycolysis. I don't think there will be long-term effects of that. It's a way of these patients are compensating to try get more ATP. The interesting thing is that these kids are using the ATP in much higher rate than what is in the control, even though they are trying to compensate. So they are using that ATP some way more than the other the controls.
Great, thank you, Lina.
Thank you.
Thank you. I think we'll move to the next speaker.
Thank you very much. We will continue right along now with and go out to Texas in the United States, where Marcy Lopez, a board member and a TANGO2 angel mom, will introduce our next guest. Marcy? I don't see Marcy yet. Are you there?
Yes, I'm here. Can you hear me?
Okay, yes, go right ahead.
Okay, thank you. Hello, everyone. My son, Sammy, was a patient that inspired the discovery of TANGO2 disease. He was part of the initial study published in 2016. Sadly, he passed away from complications related to TANGO2 in 2018. We continue his legacy to see the work being done here today to better understand this disease. I am honored to introduce Dr. Christina Miyake. She's an associate professor in the departments of pediatric at Texas Children's Hospital and molecular physiology and biophysics at Baylor College of Medicine. She also serves as the director of the Cardiovascular Genetics Inherited Arrhythmias Clinic. She specializes in the care of pediatric patients and families with inheritable arrhythmia disorders. Please welcome Dr. Miyake.
Thank you so much to everyone for this opportunity to talk to you today. I'm going to be doing a little bit more on the clinical side and then where we can go. And it's been a wonderful day of just hearing so many important studies going on. So let's go ahead. I made some new slides that you're going to see. And I just felt so inspired when I heard Sam's talk about SMA gene therapy and NGLY1. And I just want to share with you that the SMA story, the reason that the gene therapy is here today is because Aria was born with SMA and her parents began the SMA Foundation and drove the studies that discovered the gene therapy, which their daughter took. Aria is now at Yale and studying, and Dinakar Singh happens to be a family, or the whole family actually happens to be family friends of ours. Dinakar was my husband's college roommate. Grace Wilsey is the other one. She's the daughter who has NGLY1. She was born about a week before my daughter, and I met Kristen in baby group. We became family friends, and so I have this feeling that the next time there's a talk, another family is going to be on someone else's slide. So this is the beginning of TANGO2 for me. In 2014, a family came to me referred from the UAE, and she told me the story of her two boys who had unfortunately passed away from heart rhythm crisis. And when I heard the story, I just said, this is a new disease. And I'm so glad that Dr. Lalani really led this and helped discover TANGO2 disorder in 2016. And look how far we've come today. So I don't think we could be here without the Morrises and the TANGO2 Foundation and everyone involved. And a lot of it started with some of the early grant funding through the PCORI grant. It funded our first TANGO2 conference and brought us all together. And for me and our team here, I think it was the impetus to really start the natural history study. And it was because there were just so many questions about TANGO2 and so much we didn't know. So we really wanted to get more information about who these children were, and hear from the patients, hear from you as families, what was going on. And so we have since here built a team for the natural history study. You can see all of the specialists that are involved who take care of the patients that are here at Baylor, and also are really working hard to look at all of your data, to really analyze it and to help all of the researchers in terms of their studies. This study was designed to really collect information from the children, and our hope is that it'll help the doctors, families, and researchers understand, treat, and ultimately to identify a cure for TANGO2 disease. We wanted to establish a patient registry, and Dr. Lalani had the foresight to also establish a biobank at the same time, and I'll show you why that's become important to our work. So these are the faces of TANGO2. These aren't all the children, but so many of them and the families. We currently have enrolled 67 participants worldwide. Of the 67 that have enrolled, we have been able to do the personal interviews. I personally interview the families right now, of 53 children from 41 families. The average age of diagnosis is 8 years currently, but I want to show you that it's as early as 6 months. So we are making headway. The 28-year-old is because we had not yet discovered TANGO2 till later. You can see the breakdown in the sex and race. It's mostly non-Hispanic white. This is the average age currently, of the patients. And the average age is about, oh, I'm sorry. This is the current ages. And I think what this slide really, for me, represents is the fact that the children are surviving, and we have adults living into their 30s, and that's very encouraging. These are where the children and families are from. They're from all over the world, but I do see that we're missing some of the continents, and I hope that we will get more children involved, because as Dr. Mackenzie mentioned, the Broad Institute identified that there are probably at least 6,000 affected worldwide. So how many children out there just have not been diagnosed? And for me, looking at the world, I wonder whether climate or area or their differences in terms of presentation. This is what we've, the chart that we've been able to collect from the natural history study so far in terms of the developmental milestones early in life. And you can see that there's clearly a delay in the TANGO2 children, and that becomes progressive as the developmental milestones continue. The age at first presentation of symptoms. So this is when the parents told us they first started having symptoms. And you can see that in our study, all children had some symptoms before the age of 3 years. Now, interestingly, like others have mentioned, we do have one child who has never developed any symptoms. And I think, where do we go from here? We want to know why. Why are some children less affected than others? Why do some never develop symptoms? What can we do to allow all of our children to be like this? So let's go through some of the data from just what we talk about baseline symptoms, and then I'll go into the spells and the crises. So constipation, or of the GI manifestations, constipation is common. It affects about 50% of the children, and a quarter of the parents say that the symptoms get worse when the constipation is worse. But only 13% of the children are on a daily constipation medication. 16% have feeding problems or issues at baseline. What I found interesting is that 31% reported some history or episode of choking. So we do want to be careful that this, particularly because there can be swallowing problems, that we may have some problems with choking. 68% of children are frequent snackers, and that they are continuously eating and snacking about every 2 to 4 hours. A total of 16% of the children have G-tubes in this group. So where do we go from here? Why, not many people mentioned about the constipation, and so that's something that came out. Why is that? Is that part of TANGO2? Does it affect symptoms? Does it affect our absorption of certain nutrients or medications? We certainly need to understand the diet more. You've heard today, and I put this slide into my talk, about should we be limiting, or should we increase the carbohydrates, limit the long chain triglycerides, increase the medium chain, or should we avoid IV lipids during crises? Should we or should we not be giving carnitine or CoQ10? And what vitamins, cofactor supplements should be part or not part of a Mito cocktail? Well, looking as we were doing this talk, I went ahead and looked at our database to get at least one answer for you. 24 of the children in the database, or 45%, are on carnitine. 60% have had a crisis that were never on carnitine. And of the children that are currently or on carnitine, 50% have not had a crisis. So perhaps that might give us some insights, or maybe help answer some of the questions. It's not perfect. It's not a systematic data information for the researchers out there, but it's a beginning and insight into some of the questions that you had today. But really what it comes down to, in my mind, is we won't know the answers to any of these questions, whether we should or shouldn't be giving carnitine or lipids, unless we know the mechanism of the disease of TANGO2. And that's why I'm so happy to see so many different people working on different aspects in the basic science realm. So let's go to speech and intellect. 94% of parents reported that their child had intellectual delays. In terms of first words, you can see that the first words were delayed at an average rate of 18 months, and some kids not getting their first words until they were 5 years of age. 94% have trouble speaking, or there's some problems with the clarity of their speech. 65% can put 2 words together at an average age of 3.5 years, some not till 6 years. 42% can speak a full sentence. That means many of the kids cannot speak full sentences, and the average age is about 4.5 years. For sure, there's a common theme. Children, even though they can't speak, they can communicate, they can understand more than they can communicate. So I had a video here, but you've already seen this video of Lindsay's child. My question really is, he's got he's got a vocabulary, he's talking, he has sentences, maybe they're not as clear, but he definitely has sentences. Well, why do some children have no words? Why do some children have full vocabulary and speech? Is there something that we can do to increase speech and vocabulary? And can a child who currently has no words learn to speak again? So this is where we're going to go, and this is what we're trying to do to help better understand with more data. Seizures, we heard about seizures. 40% of the children in this database have had a seizure. Age at first seizure was about 3.5 years and ranged between 2 months to 23 years. So we're not out of the woods, even if we're older. The most common medications, and I want to highlight this, was valproic acid or Depakote and Keppra. And Depakote was one of the ones that was suggested to potentially be a problem. So I find it interesting, and maybe that the natural history study is perhaps helpful in that, at least in this group of children, valproic acid in many cases seem to help. One patient does have a vagal nerve stimulator and has had significant decrease in his type of atonic seizures. Importantly, what I've noted is that 7 patients reported having seizures and are no longer on seizure medications and not having seizures. So I find that interesting and an area that needs to be explored and whether or not those are true seizures or not. So other baseline symptoms, hypothyroidism is reported in 1/3. Other things that I found interesting that we're building in the database right now are just things that you've told me as parents. 50% of the children have an unusual reaction to loud noises. They don't like loud noises. They startle, they cover their ears, they jump, they blink, they drop to the floor. 1/4 of you said that your child has some unusual odor. The most common thread that I would have to say is that 77% of you said that hot weather makes the symptoms worse. But I found it interesting, cold weather does not. Let's talk about COVID. I only have one child so far that I know for sure that had COVID that did not, and it did not induce a crisis. 5 have had COVID vaccines and have not had any complications from it. Okay, so let's go into the spells and the crises that Seema talked about from the very beginning. The spells are when you're typically well, it can improve within minutes to hours. The crises are more severe. These are severe symptoms typical to the spells, but they are associated with lab abnormalities, rhabdomyolysis, elevated liver enzymes, and as you've seen, prolonged QTC on the EKG. The triggers for the metabolic crisis, as others have all mentioned, illnesses, fever, not eating well, infections. I think this is an important one. A child had a dental abscess that wasn't able to be seen. So infections like that can induce crises. I don't know about immunizations, and I think we need to know more. Some people have reported it, some haven't. It's sort of like what's out there for the immunizations, but we probably should look at it a little bit more systematically because I don't think we have definitive data, but it's been brought up. Age at first spell is about 1.5 years. So this is the first spell and can range from very early in months up to 3 years. But if you're going to have a spell, it's generally going to happen within the first 3 years. And these are the symptoms that were reported and the frequency of the symptoms. So most common: balance, muscle weakness, head tilt. What I found interesting about the head tilt is that 1/3 of you said that your child no longer has the head tilt and that the head tilt has resolved, and you can see the ages that were reported. 50% have trouble swallowing, drooling, wandering eye, and difficulty with the clarity of the speech changes. So this is something else that I think with the natural history study that I would like to see. You can see this child is really able to jump around, but then these ataxic episodes during spells, and then even during health, there's stiffness here.
Turn around and go back up.
So
come back down.
Okay, so how do we prevent the spells? Do all children develop difficulty walking and stiffness? Can these symptoms be reversed? And most importantly, in all of these differences everyone has mentioned, is it a genetic difference? Is it because we have different variations, or perhaps because someone has a 22q deletion? These are things that we need to better understand. And really, in order to do this, we need more patients in our database so we can begin to try to systematically analyze this. Crisis is the thing that we worry about the most. This is my patient Dagoberto, and he had 3 huge crises in 2017 and spent almost a year in the hospital. Remember that metabolic crises occurs with lab abnormalities, and people have asked, well, when you're not in crisis, the heart functions normally. So that's important. You don't have to worry about the heart if you're not in crises. But if you are in crisis, you can develop heart rhythm and heart failure, and you can see the abnormal rhythm that's represented here. So then we went back to the natural history database and we said, well, how many people are developing a crisis? Well, it's a lot. In our database, 75% of children have had a crisis, at least one. The average age at first crisis is a little over 4 years, and ranges from very early in life up to teenagers. Average total number of crises is 1.7 and can range up to 8. 57% of those who have had a crisis are going to develop heart rhythm problems, 48% evidence of heart failure, 22% had to be put onto life support. We call that ECMO. Of those, 83% survive. So most will survive if placed onto ECMO. Unfortunately, and this is really what we need to, I think, work on, 15% of the children in our natural history study have passed away. The average age is 6.5 years and has a wide range. I think the other important thing that I like to look at is not just, who this has been a problem in, but who hasn't had a crisis. Well, 28% of the children have not had a crisis. Who are they? Their median age is 6 years, but we have a 26-year-old who doesn't. So we need to focus a lot on these children and why they're not having crisis, and what are there differences in genetics or differences in what they're taking. Most of the deaths, again, are related to heart problems during crisis, and one due to an irreversible lactic acidosis. So there's still some information that we need to know about what's affecting these children. I want to show you a little video about how we here are trying to spread the awareness of TANGO2 and a little segue into what we are doing. And this is Dagoberto and his mother, Lorena.
My name is Lorena Gonzalez. My son was diagnosed with TANGO2 mutations. When he's in his episodes, I want to say, he has trouble walking, talking, even swallowing.
Our group here at Baylor is leading the research in TANGO2. We've been able to identify patients worldwide. Because there is no cure or treatment for TANGO2, what we've done is we've taken the patient's blood and we're able to create their heart cells. Okay. So I don't think we're the only team doing research here, but I like that we're all doing different types of research. So I want to talk a little bit about what we are doing here at Baylor. And so this work is really through Dr. Lily Zhang and her lab, and through the support, the unbelievable support of the TANGO2 Foundation to help us get where we are and where we need to go. So what we've done is we've taken the biobank and the samples that you have provided. And again, if you do have samples, mainly punch biopsies or skin biopsies, they can be sent to us. Well, we're using these and we're creating what we call pluripotent stem cells. So these cells, we're going to take a skin cell and we're going to reprogram it into the pluripotent or creator cells. These are cells that can become any cell they want in the body if we give them the right factors. So in essence, we've created a type of cell that we can make a kidney cell, we can make a brain cell, we can make a heart cell. And Dr. Zhang and I are working together to create heart cells. And we're creating the heart cells of patients and using them to study why does the heart develop these arrhythmias and what can we do to prevent it? What's the mechanism? So I just want to show you an example of how this works. This is my patient, Zoe. She has a very lethal disease called CPVT, and there's not a great treatment or cure for it. So what we did is with the Warren's lab, we took Zoe's blood, we created her heart cells in a dish. We know the mechanism of disease, which is different than TANGO2, is that we don't know the mechanism, but in this disease, we know the mechanism. So now we can take the mechanism, we got a drug company and we had 300 drugs. Well, instead of testing those 300 drugs in Zoe, we tested them in a Petri dish on her heart cells to see how she would react. And what we did is we identified one that fixed the arrhythmias that we were seeing and normalized them. And that was published recently a few years ago. And our hope is that ultimately this will go to clinical trial. So that's what we hope to do. And with the Zhang Lab and the TANGO2 Foundation support, our plan is to create 3 different patient cell lines from 3 different types of genetic variants. You've seen that there are different types and wondered whether they can potentially affect the outcome in any way, where we're going to take 3 different patients and we're going to create the cardiac cells. So our lab's really going to focus right now on the heart cells because we feel that right now this is the most urgent need. And we want to know what happens in the heart, but also ultimately that'll give us clues as to what TANGO2 does in the body and why does it cause these problems. Ultimately, long-term, if we can identify that, well, then we can, like Zoe, start to use drug treatment compounds. And as many of the people have mentioned, maybe B5, carnitine, test all of these drugs in a Petri dish rather than in our children. And ultimately, like Dr. Mackenzie said, hopefully we can identify ways to work with all of you and to cure the disease. So I think our goal overall as a group, and I mean as a group, is to get more research and funding into TANGO2. We want organizations like NIH or large organizations to provide the millions of dollars that really is needed to continue to support all of the labs doing amazing work. In our lab, we're going to focus on the natural history study and really making it more systematic data collection to answer the questions, so many of which were brought up today, and to continue basic and translational studies into the heart and the heart rhythm in particular here at Baylor. What we need, though, in order to get funded, these are very, very difficult to get funded, is we need good preliminary data. So I encourage you to enroll in the natural history study, provide samples, and to help us get the information and the data and the support we need for all, because all of this data can help, I think, all of the labs out there. So these are some of the things you can do. One of the things we are also doing is creating a 3-day diet history. And I think that's going to be, we want to know whether diet plays a role. Encourage others to participate. Keep a diary of your child's symptoms, treatments, and progression, because some children are on carnitine, others aren't. Well, write it down if you are, or if you take it off, and if you see a difference. Make sure you keep track of your child's medication supplements and notify our team if your child has a crisis, because we need to know and we need to really look at this in detail. I'm just going to leave it. This is just a little clip of the video from our chief from the cardiovascular genetics program, just talking in general about what it means to find answers to diseases.
If we really understand why is this patient getting sick, why is this patient having a rupture, why is this patient having heart failure, and we understand at a genetic basis, we are much more enabled to find the targets of these, so that we can really treat our patients so we can make them better, or perhaps prevent them from ever having a condition.
I don't know what we would have done if we wouldn't found this program. I'm not sure he would be alive today without this team.
So I'm going to stress again that the team is not Baylor. The team for me is the TANGO2 team, and that's everybody involved. That's the foundation, that's the parents, that's the children. Those are all the researchers and all of the supportive institutions that have helped us. We as a team need to find the answers and the cure, and I think we can work together. I leave with a picture of Sammy, and this is going to make me cry. This is a picture of my family in August. And we always take Sammy with us so he can see the world. So I just want you all to know that TANGO2 is a big part of my life, and I really want to help your children. And it never leaves. So thank you.
Wow, thank you, Christina. This was amazing. We love you. Thank you for being with us and doing this work. Thank you. Oh, before I take questions, I just wanted to confirm with Kara the time we have for questions. Kara?
We have about 5 minutes left for questions.
5 minutes? All right. All right. So in the chat.
Yeah, and Seema, we also had a couple of questions that I had put up at some point. I think those answers will help all of us trying to do these studies. So if we get a chance, Kasha or Seema, it doesn't have to be now, it can be after the questions.
I do have some from the list that I submitted. So one I can pick up for you. Are there any updates of information for the emergency protocol letter?
Yeah, that's a really good question. I don't think we are going to urgently right now, but I'd like to sit and really digest all of the information that was put together today. I almost think that there's so much information, it's hard to say what's right or what's wrong until we really know. But I can guarantee you that those of us that are involved, and if anyone wants to be, to help us, are going to be sitting down to relook at that and see if there's anything that needs to be changed in that emergency letter.
Great, thank you. One question is, does early treatment improve outcome? I know it's vague, but if you have any thoughts about that.
I personally, my gut says yes. The question is, what is the treatment, and how early do we need to begin? Those are just, that's my gut, just in terms of what I've seen. But again, that's why we need the natural history study, for you to give us this information so we can see. I think as children become diagnosed earlier, thanks to genetic testing and the panels that are available, I think that question and those answers are going to become more evident.
Great, thank you. I see a lot of thank yous for what you do. So thank you, Christina, in the chat. Yeah, that's all I have for you. And if anybody has a question for Dr. Miyake, you can type it in. We can try to address it.
Or you can do it offline too, that's fine. And maybe Chris, can you show some of those questions? I think it looks like maybe the attendance is lower now, but one of the reasons I want to get some answers to these questions is Dr. Mackenzie talked about readiness. And when we try to talk to the big funding agencies about where we are as a TANGO2 Foundation and group, I think some of these questions might be helpful to present that we actually have some support.
Great. I have a question from David. Has the natural history study given any evidence as to what is causing the episodic abnormalities? Are there any blood work changes?
So such a good question, David. And that's exactly, so when I talked about what we hope to do is I know Dr. Lalani is with me. We hope to expand the natural history study to make it much bigger, to get it funded, to make the data collection much more systematic. So if we could draw blood markers or drug lab markers before at baseline, when you guys are in the emergency room, to determine, is there anything that can help us identify markers of spells or crisis? These are all good questions. We don't know, but I think more of a systematic data collection and thinking about all the things that have been discussed today is going to be helpful in terms of finding the answers. But we can't do it. It's a big study. One of the things is imaging, for example. Everybody needs imaging, but we would need a lot of funding in order to be able to do this.
All right. Thank you so much, Christina. I think we all enjoyed that greatly.
Sorry,
all yours.
I get so emotional thinking about Sammy and all the children out there.
Thank you.
Thank you so much, Dr. Miyake. More and more families have been joining the natural history study, and it's very encouraging to see what can be learned when we all put information and our experiences together in one place. That completes our list of distinguished presenters for the 2021 TANGO2 Research Symposium. I'm sure all of you join me in appreciation for the efforts of these individuals as they work to better understand TANGO2 disease. We also are so thankful for the efforts of our translators that help make this important information accessible to so many more families. And before we wrap up this event, we have a few very important announcements. So first, the chat feature will now be open, and there is a link to a survey about this symposium. We welcome your feedback on this event and encourage you to click and answer just a few questions. And at this time, Mike will join us to introduce one more very important person. Mike?
Thank you, Kasha. All right, also, I'd just like to quickly thank everyone involved in our program today. Presenters, the volunteers, the researchers, and the participants. At this time, I'd like to introduce our the executive director of our foundation, Ian Geffen. Ian joined us about 1.5 years ago, and he's been instrumental in all of our efforts around building capacity around our research network, our fundraising, and the outreach to our families. So at this time, I would like to introduce Ian. Ian.
Thank you so much, Mike. Appreciate that introduction very much. So again, thank you so much for attending today's event today. And I wanted to just take a moment and share with you all the great things that are happening in the near future. So first of all, to all the researchers out there, the TANGO2 research cycle of 2 of grant funding is now open, and our foundation welcomes researchers to submit a letter of intent. You can go ahead and email info@tango2research.org or go to the foundation website for more details. Also, a quick reminder to families, doctors, and researchers that our foundation has partnered with CORDS, a rare disease registry. Both families and researchers can access this database for free, and we hope it is a useful tool in the efforts to better understand TANGO2. You can view the website or your symposium program for more information, and the website is also listed here. And families, today you've heard firsthand what can be learned from the natural history study. So if you have not yet joined, please consider adding the wealth of knowledge about TANGO2. There is no one who understands this disease better than the families living with it. And as we mentioned, the chat feature is now open. So if you just type in yes, and we'll make sure that someone reaches out to you to help get you started. Finally, we have very exciting news for all of you. Families, doctors, research, and all the supporters of the TANGO2 families and communities are all invited to Orlando, Florida, June 26th through the 28th for our second in-person TANGO2 family conference. And there's no better place than Disney World to bring our international group and families together during Disney's 50th anniversary. So at this moment, I'm going to share a short promotional video. Back to you, Kasia.
Thank you. Doesn't that look amazing? They say that Disney is a magical place, and I am sure we will all feel that magic when we gather in person for the conference. Here is our last polling question for all of you. Do you plan to attend the TANGO2 conference in Orlando, Florida? Yes, no, or maybe? I see the answers coming in. Let's see. What do we get? All right. Well, let's hope a lot of those maybes turn into yeses, because I really look forward to seeing all of you in person. It's a pretty incredible experience to meet other TANGO2 families. Well, that does it for today, everyone. Please check your email for a survey link to complete if you haven't already. We would appreciate feedback for today's symposium. I look forward to seeing many of you in person in June of 2022. And one more final thank you to our presenters, interpreters, and all of you for attending today. Goodbye for now.